quick revision. Sympathetic system originate from thoracolumbar area. It form a connection in the ganglion, which is near the spinal cord. So preganglionic fibers are small, postganglionic are long. In the ganglia, the neurotransmitter, like every ganglia, is acetylcholine, whereas the postganglionic fiber, they mainly secrete noradrenaline. So just like in parasympathetic system, as we discussed about acetylcholine, here we will discuss about noradrenaline. So noradrenaline is produced and stored here. Now, from where this noradrenaline comes, the answer is same. Noradrenaline is produced by this neuron because this is a neurotransmitter. But for noradrenaline formation, the raw material is taken from outside, which is tyrosine. So first step is tyrosine comes from outside. This is converted to dopa with the help of an enzyme called tyrosine hydroxylase. Tyrosine hydroxylase is the rate limiting enzyme in formation of noradrenaline. Now this dopa is converted to dopamine, and dopamine will enter and forms noradrenaline. This noradrenaline is stored in the vesicle. So whenever nerve impulse comes, noradrenaline is released in the synapse. Now this noradrenaline work on receptors and sympathetic action comes. We know sympathetic action is to stimulate the heart but relax most other parts of the body. Now we want to stop the action, and the major method of termination of action of noradrenaline is reuptake. It go back into the vesicle and the action stops. Just like in parasympathetic system, the main action of sympathetic system is due to presence of neurotransmitter, that means noradrenaline in the synapse. So if we increase or decrease the level of noradrenaline here, we can manipulate the sympathetic activity. And what are the options we have? The options are, we can inhibit the rate limiting enzyme, tyrosine hydroxylase. We can inhibit the entry of dopamine in the vesicle, and we can inhibit the release of noradrenaline. So three drugs we can use which decrease noradrenaline in the synapse. These are, the drug which inhibit tyrosine hydroxylase enzyme is me-tyrosine. Me-tyrosine. Again, from the name you can remember, me-tyrosine. The name says I am tyrosine. So the enzyme get confused to act at which place, because the drug is saying I am tyrosine. So in this confusion, the enzyme will stop working. So it is a competitive inhibitor of tyrosine hydroxylase. Now the drug which inhibits the entry of dopamine in the vesicle is reserpine. Reserpine, it inhibits the entry of dopamine in the vesicle. And third drug which inhibits the release of noradrenaline is guanethidine. So the three drugs, me-tyrosine, reserpine and guanethidine, they decrease noradrenaline in the synapse, so they decrease the sympathetic activity. Similarly, if we give a drug which inhibit the reuptake of noradrenaline, if noradrenaline do not go back, it will stay here, so that will produce more sympathetic action. And the drug which inhibit the reuptake, example of number 4 drug is cocaine. Cocaine is a reuptake inhibitor. So it will increase noradrenaline in the synapse, that will increase sympathetic activity. Now next thing we need to discuss about is the receptors, because noradrenaline will finally act on receptors. Now receptors of sympathetic system are of two main types. These are alpha receptors and beta receptors. Sympathetic receptors are alpha and beta. Alpha and beta. Now alpha receptors are further of two types, alpha 1 and alpha 2. And beta receptors are of three types, beta 1, beta 2 and beta 3. So we'll start the discussion from alpha 1 receptor. Alpha 1 receptor, although it is present all over the body, but you need to remember three main areas which will solve your all the concepts, and they are also helpful in solving the MCQs. And these three places are: 1. It is present in the blood vessels, where the main function is to cause vasoconstriction. Second, alpha 1 is present in the eye. The effect is to cause mydriasis. And third, alpha 1 is present in the prostatic urethra. Prostatic urethra. And we all know effect of sympathetic system on the urine outflow is to decrease the urine outflow. So alpha 1 receptor in the prostatic urethra is decreasing the urine outflow. And in which prostatic condition urine outflow is already less? It is BHP, benign hyperplasia of prostate. So what will you like to do on alpha 1 in treatment of BHP? Obviously we will like to block alpha 1 receptors. So alpha 1 blockers like prazosin, they are used for BHP. Clear? So alpha 1 present at 3 main locations: blood vessels, eye and prostatic urethra. Now coming to alpha 2 receptors. If you see, the receptors may be present here. Most of the receptors, like we discussed earlier, M1, M2, M3 and just now alpha 1. But some receptors are present here also. And alpha 2 is such a receptor. These receptors are post-synaptic, whereas this receptor is pre-synaptic. So alpha 2 is a pre-synaptic receptor. Now if you compare this system with a vehicle, with a car. So when we want to drive a car, we require two important things. One is accelerator. Second is brakes. Like when noradrenaline is released into the synapse, it stimulates these receptors that will produce the action. So this receptor, postsynaptic receptor, work like accelerator. It will produce the action. But we also require brakes in the car, because if we do not press the brakes, there may be accident. So this alpha 2 receptor act like a brake. That means whenever we stimulate alpha 2 receptors, it will inhibit the release of noradrenaline in the synapse. When noradrenaline do not come, sympathetic activity stops. So simply you need to remember that alpha 2 is acting like a brake. Alpha 2 acts like brake to sympathetic system. Alpha 2 acts like brake to sympathetic system. It is mainly presynaptic and acts like brake to sympathetic system. Now there are some alpha 2 receptor present here also, postsynaptic. And the postsynaptic alpha 2 receptors, they are indistinguishable from alpha 1 receptors. Means postsynaptic alpha 2 will work like alpha 1. That means if postsynaptic alpha 2 receptor is present in the blood vessels, they will cause vasoconstriction. If postsynaptic alpha 2 is present in the eye, they will cause mydriasis. So you can simply remember postsynaptic alpha 2 is equal to alpha 1. But they are very less, so no need to remember. But mainly you need to remember their action as a presynaptic receptor and they act like a brake. So alpha 2 receptors, their main function is to act like a brake. So alpha 1 receptor is present in blood vessels, eye and urethra, whereas alpha 2 is acting like a brake. Now coming to beta receptors. We have 3 receptors: beta 1, beta 2 and beta 3. Out of these, beta 3 receptor is mainly present on adipose tissue or fat cells. Adipose tissue or fat cells. And its main action is to cause lipolysis. Lipolysis. And we will not study beta 3 receptor anymore. Just remember it causes lipolysis. So effectively we have 2 beta receptors only, beta 1 and beta 2. And it is very easy to remember. You can remember we have 1 heart and we have 2 lungs. So beta 1 receptor is present in heart and beta 2 receptor is present in lungs. So beta 1 receptor is present in heart, means it will stimulate the heart. You know, beta 1 will stimulate the heart. Whereas beta 2 is in the bronchus, means it will relax the bronchus, it will cause bronchodilation. Now apart from heart, beta 1 is present at one more location, which is juxtaglomerular cells of kidney. So beta 1 receptor is present in heart and JG cells of kidney. In the heart it stimulates the heart, whereas in JG cells beta 1 receptor will result in secretion of renin. Whereas beta 2 receptor are present at most of the location, including the lungs. If you remember, in parasympathetic system we discussed M1, M2 and M3 receptors. The last receptor was present everywhere. So similarly here in sympathetic system also, the last receptor, which is beta 2, it is present everywhere. So first we'll write the important locations where beta 2 is present. Beta 2 is present in the lungs, means bronchus. It is present in the GIT. It is present in the urinary bladder. It is present in the glands. It is present in the uterus. It is present in the blood vessels. It is present in the skeletal muscles. It is present in the liver. The important locations of beta 2 receptors. As we discussed, sympathetic system stimulates the heart and relaxes most other parts of the body. And we know in the heart we have beta 1, so it is stimulatory. All other parts we have beta 2, so it is a relaxant. So most of these places beta 2 will cause a relaxation or inhibition. So it will relax the bronchus, it will relax the GIT, relax the bladder, relax the glands, relax the uterus. Relaxation of uterus is called tocolytic effect. Tocolytic effect. So in which disease we want to relax the uterus? It is used for preterm labor. If the labor pains start occurring before the maturity of the baby, we will want to relax the uterus, so we can give beta 2 stimulating drugs. It will relax the blood vessels also, so that means it will cause vasodilation. But important thing we discussed earlier, alpha 1 is causing vasoconstriction. So alpha 1 receptor was causing vasoconstriction, and just now we discussed beta 2 is causing vasodilation. So first of all, how to remember which receptor cause vasoconstriction and which receptor cause vasodilation. So to remember that, we have to go back to nursery class where we were taught about A, B, C, D. And in nursery class we were also told the counting 1, 2. Now just we need to put the arrows. So you can remember A1 means alpha 1, it will cause C means constriction. B2 means beta 2, it will cause D for dilation. So alpha 1 will cause vasoconstriction and beta 2 will cause vasodilation. So this we have remembered which receptor cause vasoconstriction, which cause vasodilation. Now the question is, both the receptors are of sympathetic system. So when sympathetic system is stimulated, what will happen to blood vessels? Because these two have opposite effects. So the effect on the blood vessel will depend upon which blood vessel has which receptor in more quantity. If a blood vessel contain more alpha 1 receptor, that will contract. If a blood vessel contain more beta 2, that will dilate. So alpha 1, if it is more, there will be vasoconstriction. If beta 2 is more, there will be vasodilation. Now the question is, which blood vessels contain more alpha 1 and which blood vessels contain more beta 2? Now this is also easy to remember. Now suppose a lion come in front of us. So what we can do at this time? Either we can fight with the lion and kill the lion. Obviously we are not Rajnikant to kill the lion. And the second, which is better option, is to run away. So when we see a lion, we will try to run away. And we can run away if we have power in the muscles. And we will also require power in the heart. So we do not get tired and we can easily run away. So whenever we want to run away in case of emergencies, we require sympathy. So sympathetic system will be activated and sympathetic system will help us in running away. That means when sympathetic system is activated, it should increase the blood flow to the muscles and increase the blood flow to the heart. So that means blood vessels of heart, which is coronary arteries, and blood vessels of skeletal muscles, they should dilate when there is sympathetic overactivity, and dilation will occur when there is more beta 2. So skeletal muscles and coronary arteries, they contain more beta 2 as compared to alpha 1 receptors. So that means whenever sympathetic system is overactive, we can quickly run away. The question is, normally we have 5 liters of blood in the body. When a lion come in front of us, it will not become 10 liters. So when the blood remains 5 liters from where it comes. So what happens is, at all other blood vessels, alpha 1 is more. Blood vessels of skin, blood vessels of internal organs, they contains more alpha 1 receptors. So whenever there is an emergency, there will be vasoconstriction in these areas because alpha 1 is more. and this blood is shifted to heart and muscles, so person can run quickly. So alpha 1 receptor is more in skin and internal organs, whereas beta 2 is more in the blood vessels of heart and muscles. So this is effect of sympathetic system on the blood vessels. Now next is skeletal muscles. Apart from the blood vessels, beta 2 receptor is also present on the skeletal muscle spindle, and stimulation of beta 2 receptor in the muscle spindle result in tremors. That's why whenever there is sympathetic overactivity, there is presence of tremors. Like we develop tremors when the lion comes in front of us. We develop tremors in Viva exams because sympathetic system is overactive. We also develop tremors while proposing someone, again because sympathetic system is overactive. So sympathetic activity lead to tremors. Now lastly, there is presence of beta 2 in the liver. Now before discussing the action of beta 2 in the liver, we need to answer some important questions. Which is more dangerous, hypoglycemia or hyperglycemia? Obviously, hypoglycemia is more dangerous. Hyperglycemia means diabetes. You must have seen many diabetic patients who have uncontrolled blood sugar and they do not develop problem for many years. But hypoglycemia, if it is present for just 1 minute, the person will go to coma. So hypoglycemia is an emergency. So sympathetic system help us in protecting from emergencies. So sympathetic system will try to protect us from hypoglycemia. So how it will protect? So whenever the person develop hypoglycemia, sympathetic system will become overactive. And whenever sympathetic system is overactive, it will stimulate beta 1, beta 2, and in case of sweat glands, sympathetic cholinergic system. So when beta 1 is stimulated, the person will develop tachycardia, heart is stimulated. And when severe tachycardia occurs, it can lead to palpitations. Stimulation of beta 2 we just discussed will lead to tremors. And stimulation of sympathetic cholinergic fibers in the sweat glands will lead to sweating. So when a person develops sympathetic overactivity, as in case of hypoglycemia, the person will develop tachycardia, palpitation, tremors and sweating. So these are called as warning symptoms of hypoglycemia. Warning symptoms of hypoglycemia. That means hypoglycemia itself tells that I am present by causing these symptoms. Remember, hypoglycemia is more likely in diabetic patients. So if they skip meals, if they take anti-diabetic drug, they may develop hypoglycemia. So whenever they develop hypoglycemia, these symptoms will come. These are the warning symptoms. That means whenever these symptoms come, the person should take sugar or biscuit. So hypoglycemia will be reversed and person will not go to coma. This is very important. Warning symptoms of hypoglycemia. So this should be told to every diabetic patient. Now suppose a person comes to a doctor like me who is not aware about these symptoms. We do not tell him anything about these symptoms. When these symptoms are not told, so person will not take sugar. So person has all these symptoms but the person do not take any sugar. So what will happen? Will the person go to coma? No, still the person do not go to coma because now the beta 2 receptor which is present in the liver will be stimulated. And we know liver is site of metabolism. So when beta 2 is stimulated in the liver, it will shift the metabolism in such a way that blood sugar start increasing. That means all the biochemical processes which are forming blood glucose will be stimulated and which are consuming will be inhibited. So there will be stimulation of gluconeogenesis. There will be stimulation of glycogenolysis. There will be inhibition of glycogenesis. So basically, by changing the metabolism, it will increase blood sugar. And when blood sugar increases, the hypoglycemia will be reversed. So that's why sympathetic system is very, very important to protect from hypoglycemia. It protects by two main mechanisms. One by causing a warning symptom and second by reversing the hypoglycemia. This is the reason that if we give beta blocker to a diabetic patient, they are very dangerous drugs, because if we give beta blocker to a patient who has diabetes, first of all the symptoms will not come, so they result in masking of warning symptoms. That means even if the person develops hypoglycemia, the symptoms will not come. The person will never come to know that he is having hypoglycemia. So the person will not take sugar. Now second thing, if a person do not take sugar, the liver will reverse the hypoglycemia, but we have blocked the same receptor. That means even reversal cannot happen. So there is high chance that the person can go into coma. So beta blockers are contraindicated in diabetic patients. Beta blockers are contraindicated in diabetic patients. Now one very important question which is asked is, which symptom of hypoglycemia will be present even if a person is taking beta blockers? The answer is sweating. Remember, sweating is mediated by acetylcholine, that means M3 receptors, and we have blocked beta 1 and beta 2 only. So sweating is the only reliable symptom of hypoglycemia in diabetic patient taking beta blockers. Even if beta blocker is taken, sweating still will be present. So we have discussed the location of different sympathetic receptors. So alpha 1 receptor, it is present in the blood vessels, eye and urethra. Alpha 2, the main function is to act like a brake. Beta 1 is mainly present in heart and JG cells, and rest everywhere beta 2 receptor is present. So with this basic understanding, now we can discuss the drugs acting on these receptors. Just like parasympathetic system, the drugs acting on sympathetic system, they can also be divided into sympathomimetics and sympatholytics. Sympathomimetics are those which stimulate the sympathetic system, and sympatholytics are those which block the sympathetic system. So we will start the discussion from sympathomimetic drugs. Now sympathomimetic drugs, they are further classified into directly acting and indirectly acting. Directly acting will stimulate any of those receptors, alpha 1, alpha 2, beta 1, beta 2. Whereas indirectly acting drugs are of two main types. One we already discussed, the drugs which can inhibit the reuptake. If a drug inhibits the reuptake of noradrenaline, it will increase sympathetic activity. And the main drug which acts by inhibiting the reuptake of noradrenaline is cocaine. Another drug is tricyclic antidepressants. These drugs will cover later on. Cocaine will cover in anesthesia, and tricyclic antidepressants will cover in CNS. Now second group of drugs which act by in indirect action is drugs acting by displacement. Drugs acting by displacement. The example is tyramine. Tyramine. First of all, how tyramine works? Now we know that noradrenaline is stored in this vesicle, and every vesicle has a fixed capacity. Suppose this is able to store 50 molecules of noradrenaline. So normally all of them are neurotransmitter. If we give a drug like tyramine, which has the capacity to enter the vesicle, suppose we give 25 molecules of tyramine. So these 25 molecules of tyramine will enter the vesicle. So total will become 75 molecules in the vesicle, but it cannot store 75. So what will happen is, it will displace 25 molecules of noradrenaline in the synapse, which will start working on the receptors, and that will produce the sympathetic action. So this is called action by displacement. Drug will enter the vesicle and push noradrenaline into the synapse to produce the action. Now what is remaining in the vesicle is 25 molecules of tyramine and 25 molecules of noradrenaline. If we give second dose of tyramine, 25 more molecules, so total will become 50 tyramine in the synapse and 25 noradrenaline. Again 75 it cannot store, so these 25 will also be displaced, and again sympathetic action will come. Now what is remaining in the vesicle is all 50 molecules of tyramine. If we give third dose of tyramine, 75 tyramine will become. Now there is no noradrenaline which can be displaced, so now tyramine is displaced. So when tyramine comes in the synapse, it cannot act on the receptor, so the action will suddenly stop. So this phenomenon is known as tachyphylaxis. Tachyphylaxis. It is divided into two parts. Tachy means fast, phylaxis means tolerance. So when we give a drug like tyramine, they will produce action for 2 or 3 doses, but after that suddenly the tolerance will occur to their action. Remember, normally tolerance is slow to develop, but in these drugs the tolerance is very rapid to develop. So tyramine like drugs, they act by displacement, and all the drugs acting by displacement can show the phenomenon of tachyphylaxis. So apart from tyramine, the other drugs which act by displacement are, we have tyramine, ephedrine, pseudoephedrine and amphetamines. Out of these, tyramine, it acts by displacement only this mechanism, indirect action, it causes displacement of noradrenaline, whereas the other 3 drugs, ephedrine, pseudoephedrine and amphetamines, although they also cause a displacement, that means indirect effect is there, but after some time when they come in the synapse, they can also act on the receptors, means they have mixed action, they have both direct effect as well as indirect effect. Clear? Now important points regarding the individual drugs. Tyramine is present in large quantities in cheese. Cheese contains plenty of tyramine. The clinical importance we will discuss little while later. Next 2 drugs, ephedrine and pseudoephedrine, they act as nasal decongestants. So they are used in cold when the nasal congestion is present. And lastly, amphetamines. Amphetamines are the drugs which can cross the blood-brain barrier. So they enter the brain and they produce 2 important effects. One, they reduce sleep, and second, they increase attention span. So they reduce sleep and increase attention span. So that means they are which type of drugs? Yes, they are called CNS stimulants. Amphetamines are CNS stimulants. They reduce sleep and increase attention span. So the use of amphetamines, although amphetamines are highly addictive drugs, but the use is based on these 2 functions only. The first function is they reduce sleep, and this action is utilized in a condition called narcolepsy. Narcolepsy is a disease which is characterized by sleep attacks. In narcolepsy, the patient develops sleep attacks. And sleep attacks literally means attacks. The person can suddenly sleep. So you can assume a person is driving a bike, suddenly sleeps. A person is swimming, suddenly sleeps. So it can lead to fatal accidents. So we do not want these sleep attacks. So we give a CNS stimulant drug like amphetamines. They decrease sleep, so that will lead to decrease in number of sleep attacks. Now second action of increasing the attention span, it is utilized in a disease called attention deficit hyperkinetic disorder, ADHD. Attention deficit hyperkinetic disorder. This is a disorder seen commonly in children. Attention deficit does not mean that parents are not giving attention. Attention deficit means child has less attention span. Less attention span means the child is not able to concentrate on anything. So when the child is not able to concentrate, the child get bored easily. So a child start playing with some game, not able to pay attention. So the child get quickly bored. So child will take another game and start playing again. So again get bored. So again start playing with another game, again bored. So after some time the child will think that I have nothing to play. So the child become irritable and that lead to hyperactivity. So hyperactivity is indirect result of inattention. So primary problem is inattention, that is leading to irritation and that is leading to hyperactivity. So in ADHD the primary problem is inattention. So when we give amphetamines, they increase the attention span, so that will treat the ADHD. And the drug of choice for ADHD is methylphenidate. Methylphenidate is a drug of choice for ADHD. Clear? So that is all about the indirectly acting sympathetic drugs. So drugs acting by inhibiting the reuptake and drugs acting by causing the displacement. Now we'll move to directly acting drugs. The drugs will directly stimulate any of the sympathetic receptors, alpha 1, alpha 2 or beta 1 or beta 2 receptors. Now directly acting drugs, we can divide them into catecholamines and non-catecholamines. Directly acting drugs may be divided into catecholamines and non-catecholamines. The first question is, what is a catecholamine? Catecholamine is actually a chemical name which consists of catechol and amine. If you remember chemistry, this chemical structure of dihydroxybenzene, it is also known as catechol. And if amine group is also present, it becomes catecholamine. That means any drug having this type of chemical structure is called catecholamine. If this is absent, it is called non-catecholamine. The question is, we have already discussed so many drugs, but we never talk about the chemical structure. But here we are dividing the drugs based on the chemical structure. So there must be something important. And important thing is that this chemical structure of catecholamine, it can be recognized by some enzymes in the body. And the name of those enzymes are COMT, catechol orthomethyl transferase. So this enzyme can recognize any drug which contains this chemical structure. And this enzyme is present in large quantities in GIT. So that means if any person takes any catecholamine orally, already COMT is waiting there to break it down. So no catecholamine will be effective orally. So that is the only important thing to know, that catecholamines are not effective orally, whereas non-catecholamines may be effective orally. Now catecholamines, they are further divided into endogenous catecholamines and exogenous catecholamines. Endogenous catecholamines means they are normally present in the body, whereas exogenous means they are given from outside only. The endogenous catecholamines include adrenaline, noradrenaline and dopamine. Adrenaline, noradrenaline and dopamine, they are endogenous catecholamines, whereas exogenous catecholamines include dobutamine, isoprenaline, and phenoldopa. Adrenaline, noradrenaline and dopamine are endogenous, whereas dobutamine, isoprenaline and phenoldopa are exogenous catecholamines. So first we'll cover catecholamines, then we will move to non-catecholamines. So among these drugs, we'll start the discussion from dopamine. Dopamine. Now for knowing about any drug, the most important thing is to know about on which receptors it works. Dopamine work on three main receptors. These are D1, beta 1 and alpha 1. Important thing is in this sequence. Sequence means at a very low dose it stimulates D1. When we increase the dose, it will start stimulating D1 and beta 1 both. And at high dose it can stimulate all three receptors. So if you remember the dose for beta 1, other two you can automatically remember. The dose of dopamine for stimulation of beta 1 receptors is 2 to 10 microgram per kg body weight per minute. So if we give dopamine infusion at a rate of 2 to 10 microgram per kg body weight per minute, it can stimulate beta 1. That means if we give it less than 2, it will stimulate only D1. If we give more than 10, it can stimulate all three receptors. Now we already discussed about beta 1 and alpha 1. Beta 1 is mainly present in heart and alpha 1 is mainly present in the blood vessels to cause vasoconstriction. Now we did not discuss about D1 receptors. D1 receptors are also present in blood vessels, but their main function is to cause vasodilation. D1 receptors are present in all the blood vessels of the body and they cause vasodilation, but they are highest concentration in the renal blood vessels. They are present in all the blood vessels, but maximum concentration is present in the renal blood vessels. So when we give dopamine, it can stimulate D1, beta 1 and alpha 1. So based on that, we can find the uses of dopamine. Like dopamine stimulate the beta 1 receptors, means it will stimulate the heart. So in which condition we will want to stimulate the heart? Yes, we want to stimulate the heart in congestive heart failure. So dopamine is used in congestive heart failure and the dose of dopamine will be 2 to 10 microgram per kg body weight per minute. Now dopamine can also stimulate alpha 1 receptor which will cause vasoconstriction. So in which disease we will want to cause vasoconstriction? Yes, we'll want to cause vasoconstriction in patients with shock. So dopamine, when given in high doses, will cause vasoconstriction that will increase the blood pressure so it can treat shock. But the additional advantage of dopamine is at high doses it stimulates all the three receptors. That means it will stimulate D1 receptors also. And by stimulating the D1 receptor, it will cause vasodilation in kidney. When vasodilation occurs in the kidney, GFR increases. And when GFR increases, that will lead to more urine outflow. So dopamine in particular is drug of choice for a patient having shock with oliguria. It will treat not only shock, but it will also reverse the renal failure. So dopamine is a drug of choice for patient with shock and oliguria. Shock plus oliguria, dopamine is drug of choice. So that is the important thing to remember about dopamine. One more thing you can find out, the drug whose name contains dopa, it will stimulate D1 receptor. If dopa is not present in the name, it will not stimulate D1 receptor. Now why we are talking like that? The second drug we are going to discuss, the name is very similar to dopamine, dobutamine. But if you see carefully, dobutamine do not contain dopa in the name. So dobutamine do not act on D1 receptors. So that is the most important thing to remember. Dobutamine do not act on D1 receptors. Rather, dobutamine primarily work on beta 1 receptors. Dobutamine mainly stimulate beta 1 receptors. Because it is mainly acting on beta 1 receptors, so it is mainly used for congestive heart failure. So major use of dobutamine is congestive heart failure. It stimulates mainly beta 1 receptors. Now if you see another drug, phenoldopam, see it carefully, its name also contains dopa. Phenoldopam also contains dopa in the name. So that means it will also stimulate D1 receptor. If you read the name again, phenoldopam, it will look like only dopa. That means only dopa means it stimulates only D1 receptor. Unlike dopamine, which at high doses starts stimulating beta 1 and alpha 1 receptors also, phenoldopam even at high dose stimulates only D1 receptors. So when it stimulates only D1 receptor, it will cause only vasodilation. And when it is causing vasodilation, we can utilize it in hypertensive emergencies. So phenoldopam can be used in hypertensive emergencies. It will cause vasodilation and treat the hypertensive emergencies. So that is all about the dopamine, dobutamine and phenoldopam. Now we are left with the three drugs in this category. These are adrenaline, noradrenaline and isoprenaline. We will cover all the three drugs together. Adrenaline, noradrenaline and isoprenaline. Adrenaline is also called as epinephrine. Noradrenaline is also called as norepinephrine. Now, for knowing about these drugs, again the most important thing is to remember on which receptors they work. And it is very easy to remember. You can remember A for adrenaline, A for all the receptors, A for all the receptors. All the receptors means alpha 1, alpha 2, beta 1, beta 2. We have four main receptors. So adrenaline stimulates all the four receptors. Then second is Na means noradrenaline. So you can remember Na means not all. So we will start writing alpha 1, alpha 2, beta 1 and suddenly we will remember that not is also written. So we will not write beta 2. So it acts on three only, alpha 1, alpha 2 and beta 1. Now isoprenaline it acts only on beta receptor, beta 1 and beta 2 only. So adrenaline act on all the 4 receptors. Noradrenaline not all, that means last receptor it will not work, and isoprenaline only beta receptor. Clear? So now we can discuss the effect of these drugs on blood pressure and heart rate. Effect on BP and effect on heart rate. Now blood pressure is of two types, systolic and diastolic. Systolic BP and diastolic BP. So as the name tells, systolic blood pressure, systole means contractility of heart, and heart contractility of heart depend upon which receptor? Yes, it depends upon beta 1 receptors. So if a drug stimulates beta 1, it will stimulate the heart, so it can increase systolic BP. And if we see which drugs out of the 3 stimulate beta 1 receptors, adrenaline stimulate beta 1, noradrenaline also stimulate beta 1, isoprenaline also stimulate beta 1. So all 3 stimulate beta 1 means all 3 will increase systolic blood pressure. So all the 3 drugs, they tend to increase systolic blood pressure by stimulating beta 1. Now the question is, what will the effect on diastolic blood pressure? Diastole means when heart is relaxing. When the heart is relaxing, now which factor maintain the blood pressure? Which factor? Peripheral vascular resistance. So in simple manner, peripheral vascular resistance means effect on the blood vessels. If there is vasoconstriction, there is more BP. If there is vasodilation, there will be less BP. So that is diastolic blood pressure. So diastolic blood pressure depend upon blood vessels. And which receptor is present on blood vessels? Yes, we have 2 receptors, alpha 1 and beta 2, which have opposite effects. Remember nursery class, we discussed A, B, C, D. Alpha 1 cause constriction, beta 2 cause dilation. So it will depend upon alpha 1 and beta 2. And if you see, adrenaline act on alpha 1 as well as beta 2. That means by stimulating alpha 1 it causes vasoconstriction, and by stimulating beta 2 it will cause vasodilation. So the 2 will tend to cancel each other. So the net effect will be negligible. Neither much increase nor much decrease. On the other hand, noradrenaline stimulates alpha 1 which cause vasoconstriction, but it has no effect on beta 2. That means only vasoconstriction. Only vasoconstriction means it will increase the diastolic BP. Lastly, isoprenaline do not act on alpha, only act on beta 2. Beta 2 we know is causing vasodilation, and vasodilation will lead to decrease in diastolic blood pressure. So we noted that all the 3 drugs have different effects on blood pressures. Adrenaline has negligible effect, noradrenaline increased diastolic BP, and isoprenaline decreased diastolic BP. Systolic BP increased by all 3, but diastolic BP all 3 have different effects. So now we can discuss the effect of these drugs on heart rate. Now one thing to remember, whenever we discuss the effect of any drug on heart rate, we always discuss under 2 headings. First, what is the direct effect on heart? And second, what is the indirect effect on heart? Now starting with the direct effect on heart. So direct effect on the heart means the drug will directly go to heart and stimulate its receptors or inhibit its receptors. And which receptor is present on the heart? Yes, it is beta 1 receptor. So any drug which stimulates beta 1 receptor will stimulate the heart, increase the heart rate. And we discussed already all 3 drugs stimulate beta 1 receptors. So all 3 drugs will try to increase heart rate by direct action. All 3 drugs increase heart rate. Now what is this indirect effect? Now indirect effect is the compensatory response of the body. Remember, our body has compensatory ability for everything. If anything goes wrong in the body, our body will try to rectify that automatically. So that is called as indirect effect. Now if the BP increases, body will try to decrease the BP. If the BP decreases, body will try to increase the BP. But for that, body should contain some sensor which can tell that BP is increased or decreased. Only then the body can change the BP. So that sensor is present in the blood vessels, and name of that sensor is baroreceptors. So blood vessel contains baroreceptors. Baroreceptors. Now which blood pressure baroreceptors sense? as they sense mainly mean blood pressure. But as we know, mean blood pressure, the major component is diastolic BP. So you must be knowing the formula. Mean blood pressure is equal to diastolic blood pressure plus 1/3 of pulse pressure. So the major component of mean BP is diastolic BP. So we can safely assume that baroreceptors mainly sense diastolic blood pressure. So what happens when the diastolic blood pressure increases? When diastolic BP increases, baroreceptors get the information. So baroreceptors are stimulated. And whenever baroreceptors are stimulated, they will immediately pass this information to the CNS, brain and spinal cord. Baroreceptor pass this information to CNS with the instruction that diastolic BP is more, please reduce this BP. But our CNS has only two arms, one is sympathetic system, one is parasympathetic system. So as the information is we have to reduce the BP, so which arm will be stimulated? Yes, it will be parasympathetic system. So whenever the diastolic BP increases, it will stimulate the parasympathetic system. And what is the effect of parasympathetic system on heart rate? It decreases heart rate. So this is the indirect effect on heart rate. So whenever diastolic BP increases, it stimulates the baroreceptors. Baroreceptors stimulate the parasympathetic system of the CNS, and that will result in decrease in heart rate. The opposite is also true. Whenever diastolic BP decreases, when diastolic BP decreases, again baroreceptor get the information. They pass the information to CNS with the instruction that BP is low, kindly increase the BP. And for increasing the BP, the CNS will stimulate the sympathetic system. And when sympathetic system is stimulated, the heart rate increases. So this is the indirect effect on heart rate. So if you see carefully, whenever diastolic BP increases, the indirect effect is decrease in heart rate. Whenever diastolic BP decreases, the indirect effect is increase in heart rate. Increase in diastolic BP will decrease the heart rate. Decrease in diastolic BP increase the heart rate. So you can safely remember that indirect effect on heart rate is opposite to diastolic BP. If diastolic BP increases, heart rate decreases. If diastolic BP decreases, heart rate increases. So if we put this in the table, adrenaline, it has no effect on diastolic BP. So there will be no indirect action also. Noradrenaline, it increases diastolic BP. So indirect effect on heart rate will be opposite. That means it will decrease heart rate. Isoprenaline decrease diastolic BP. So indirect effect will be to increase heart rate. So if we see the final effect on heart rate, it will be simple arithmetic sum of these two heart effects, direct and indirect effect. So adrenaline 1 plus 0 is equal to 1. Noradrenaline 1 minus 2 will be minus 1. Isoprenaline 1 plus 2 will be 3. So final effect on heart rate, adrenaline increase the heart rate, noradrenaline decrease the heart rate, and isoprenaline significantly increase the heart rate. Now this table is very, very important for MCQ points of view. So some of the important questions which are asked from this table. First question is, which drug increase systolic as well as diastolic BP but cause bradycardia? The answer is noradrenaline. Systolic and diastolic BP is increased, but bradycardia occurs. Second question which is asked is, which of the following drug can cause maximum tachycardia? The answer is isoprenaline. Isoprenaline cause maximum tachycardia. One more question which seems very simple, but highly likely that the question can be marked wrongly. Simple question is, what is effect of noradrenaline on heart rate in a normal person? Yes, it will cause bradycardia. When it is so simple, why it is likely to be marked wrongly? The reason is, this table is not present in front of our eyes during the exam. At that time, we were simply thinking like noradrenaline is a sympathetic drug, so it should cause tachycardia. But what is actually happening is, noradrenaline is a sympathetic drug, but it is causing bradycardia because indirect effect is very strong. So remember, noradrenaline do not cause tachycardia, it causes bradycardia. Next question, which is slightly difficult. is what is effect of noradrenaline on heart rate in a patient with transplanted heart. Now to answer this question, we need to know the difference between a normal heart and a transplanted heart. The main difference is that a normal heart and transplanted heart, otherwise they are very similar. That means both contain beta-1 receptors. But the main difference is that in a transplanted heart, we are taking the heart from one person's body and putting it in some other person's body. So when we are putting the heart in other person's body, we will not be able to make small neural connections. So that means those sympathetic parasympathetic fibers cannot be joined. So that means a transplanted heart will not show any indirect effect because there is no sympathetic or parasympathetic supply to that. So in a transplanted heart, indirect action do not come. Only direct action comes. So when only direct action comes, the effect of noradrenaline will be to cause tachycardia. So this is important to remember. In a normal person, noradrenaline causes bradycardia, but in a patient with heart transplantation, noradrenaline causes tachycardia. The reason is simple. In a transplanted patient, indirect effect do not manifest. So now we can discuss the uses of these drugs, and again they are easy to remember. Just from the receptors you can remember the uses. So we have adrenaline, we have noradrenaline, we have isoprenaline. Isoprenaline act on beta-1 and beta-2. Noradrenaline, not all we discussed, alpha-1, alpha-2, beta-1. And adrenaline A for all means alpha-1, alpha-2, beta-1, beta-2. So starting from isoprenaline, it stimulates the beta-1 receptors which are present in heart. So isoprenaline is used to stimulate the heart for congestive heart failure. It stimulates the beta-2 receptors. So we can utilize this in bronchial asthma. Beta-2 cause bronchodilation. So in asthma we want to cause bronchodilation. So we can use in CHF, we can use in some patients of asthma. Now noradrenaline, it stimulates alpha-1 receptor which will increase the blood pressure. So we can use it in shock. It also stimulates beta-1 receptor. So we can use it in congestive heart failure. Adrenaline, technically speaking, it stimulates all the receptors. So can be used for almost all these indications, shock, CHF, asthma. But practically, adrenaline has very few uses. The reason is adrenaline is very toxic. Slight overdose can cause arrhythmia and the person can die. So adrenaline has specific uses only, and the important uses of adrenaline to remember. Adrenaline is a drug of choice for anaphylactic shock. Adrenaline is a drug of choice for anaphylactic shock. Drug of choice for anaphylactic shock. The first question is, in this condition there is shock. That means BP is low. So we want to increase the BP. If we look at the table, we'll find that for increasing the blood pressure, noradrenaline is a better drug. It increases systolic as well as diastolic BP. Whereas adrenaline is mainly acting on systolic BP, has negligible effect on diastolic BP. So then why do we prefer adrenaline, not noradrenaline? Noradrenaline is better to increase BP, so we should use noradrenaline. But adrenaline is preferred, adrenaline is drug of choice. The reason is anaphylaxis is also written in this case. And anaphylaxis mostly manifests as bronchoconstriction. So that means to treat the anaphylactic shock, we need to cause bronchodilation also. Remember the difference between adrenaline and noradrenaline? A for all and A for not all. That means noradrenaline do not act on beta-2 and it cannot cause bronchodilation. So if we give noradrenaline, it will increase the BP, but the person may die because of respiratory problem. On the other hand, adrenaline stimulates all the receptors, so it can treat shock also and it can cause bronchodilation also. That's why adrenaline is a drug of choice for anaphylactic shock. Now, route of choice is intramuscular. Adrenaline is preferred by intramuscular route. If that is not given in the option, then you can mark subcutaneous. But remember, IV should not be the answer because intravenous adrenaline is highly arrhythmogenic. It can lead to death of the person. The route of choice is intramuscular. If not in the options, then subcutaneous. Now, third important question, what is the concentration of choice? The concentration of adrenaline used is 1:1000. 1:1000 means 1 gram of adrenaline is dissolved in 1000 ml of solution. 1 gram adrenaline is dissolved in 1000 ml of solution, and 0.5 ml of this solution is given as intramuscular dose. So 0.5 ml of 1:1000 solution is dose. So route of choice is intramuscular, drug of choice is adrenaline, and concentration of choice is 1:1000 ml. 99% of the patient will improve with this dose. If a person do not improve, then we need to repeat. If a person do not improve, then repeat the same intramuscular dose, but important thing is within 10 minutes. It is a serious condition, we cannot wait for long time, so we need to repeat adrenaline within 10 minutes. Most of the people will respond to that dose. If still the person do not respond, then in the desperate circumstances we can give IV adrenaline. But IV adrenaline, the concentration used should be 1:10,000. That means we need to dilute it 10 times, only then we should give intravenously. 1:1000 IV adrenaline will cause arrhythmia and the person may die. So if we use intravenous, it is 10 times diluted, and the indication of intravenous is when the intramuscular route has failed repeatedly. So that is the adrenaline and anaphylactic shock. Adrenaline is a drug of choice for anaphylactic shock. Now apart from anaphylactic shock, second use of adrenaline. Adrenaline is also used in cardiac arrest. Now what do you mean by cardiac arrest? Cardiac arrest means heart has totally stopped. Heart is not working at all. So when the heart is not working, what will be the clinical presentation of the patient? Obviously the person will be unconscious. No blood is going to brain, person is unconscious, not responding. There will be no pulse, there will be no heart rate. Clear? So that means the person is almost dead. So what we will do in this person which has no pulse, no blood pressure, no heart rate, person is not responding at all. So what we will do? Yes, we will give basic life support, or in simple language what we say, CPR, cardiopulmonary resuscitation. So how to do CPR? What is the sequence of events? The sequence of events is CAB. C means chest compressions. First we will give chest compression because heart is not contracting. So what we need to do is from outside we will press the heart through the ribs and compress the heart against vertebra so that heart can be squeezed and the blood can go out. Clear? So chest compressions. Second thing is airway patency. We need to open the airway. And third is breathing. Through that open airway we can give breathing through ambu bag or ventilator or mouth to mouth breathing, whatever is available. Okay? So we will start CPR. Cardiopulmonary resuscitation. We start giving chest compressions, airway and breathing. Now have you ever given CPR to any person? If you have given or you have seen someone giving, CPR is a very tiring job. Like we need to compress the heart against the ribs. It requires a lot of power. It requires a lot of effort. And plus we need to give 100 times every minute. So that means we need to press the heart strongly 100 times in 1 minute, and the person will tire very easily. While giving CPR, just in 2 minutes or 3 minutes, it seems like we have run a marathon. We are so much tired. Okay? So we have started doing CPR, but the person is not responding. So then we try giving the drugs. And the drug which we use is adrenaline. Adrenaline. By which route adrenaline is given for CPR? It is given intravenously. Adrenaline is given intravenously for cardiopulmonary resuscitation. So what will be the concentration of adrenaline when we give it IV? Yes, the concentration of adrenaline is 1:10,000. Remember in anaphylactic shock, when we give intramuscular it was 1:1000, but when we give it IV it was 1:10,000. The same here, when we give intravenously it is 1:10,000. Now suppose we are not able to find the vein. Remember, the person is unconscious, but heart is not pumping, the veins must have collapsed. So high chances that we will not be able to find a vein. So when we are not able to find the vein, then how we will give adrenaline? Yes, in that case we will give adrenaline by intraosseous route. So the preferred route is IV. If it is not possible, then we give intraosseous. Intraosseous means we have a special needle. Through that needle we will inject adrenaline in the tibia. The venous plexus around the long bones is usually patent even in such circumstances, so adrenaline can be absorbed from there. Now suppose we are not able to find the vein, we cannot give IV, and we do not have the needle to give in the trachea, so intraosseous is also not possible. Then what we will do? By which route you will give adrenaline? The third example is endotracheal. We will intubate the person and through the endotracheal tube we will inject adrenaline. So these are the routes in this sequence. And when will you use intracardiac adrenaline? Intracardiac adrenaline is given only in one situation, that is in Hindi movies. Remember, intracardiac adrenaline has been banned long ago. In 2005 it was banned. Intracardiac adrenaline is not given at all. Okay? The preferred route is IV, if not possible intraosseous, if not possible endotracheal. Okay? So these are the two important uses of adrenaline: anaphylactic shock and cardiac arrest. Okay. Now we'll move to one very important phenomenon which is called as vasomotor reversal of tail. Now to understand this, first of all we'll again discuss adrenaline. We discussed has action on 4 receptors: alpha 1, alpha 2, beta 1, beta 2. And out of these 4 receptors, which receptors are present on the blood vessels? Yes, alpha 1 and beta 2. And they have opposite effects. Remember, we discussed A, B, C, D. So alpha 1 will cause vasoconstriction and beta 2 causes vasodilation. Now one more important thing to remember now is alpha 1 receptor is a strong receptor, whereas beta 2 receptor is a sensitive receptor. Now what is the meaning of this thing is, beta 2 is sensitive means even if we give low dose of adrenaline, it can stimulate beta 2. But that low dose cannot stimulate alpha 1. So alpha 1 requires high dose. So when we give high dose of adrenaline, both beta 2 and alpha 1 will be stimulated. And when both are stimulated, alpha 1 will have more effect because it is a strong receptor. So if we give low dose adrenaline, it stimulates only beta 2, which will lead to vasodilation. But if we give high dose adrenaline, it stimulates alpha 1 and beta 2 both. But the effect of alpha 1 will predominate, so the net effect will be vasoconstriction. Now to understand this more easily or more effectively, we will make it mathematical. Suppose alpha 1, beta 2 receptors, they are sensitive, so they can be stimulated by just 10 molecules of adrenaline. Whereas alpha 1 cannot be stimulated by low dose. So stimulation of alpha 1 suppose require 50 molecules of adrenaline. So if we give 100 molecules of adrenaline by IV route, if we give 100 molecules of adrenaline by IV route, which receptor will be stimulated? So both will be stimulated, alpha 1 and beta 2. And when both are stimulated, the net effect will be due to alpha 1 receptor, because that is a strong receptor. So this is the normal blood pressure. When adrenaline high dose is given, 100 molecules are given, BP increases. Now why BP increases? Although it is stimulating both alpha 1 and beta 2, alpha 1 is a more strong receptor as compared to beta 2. So that lead to increase in blood pressure. But after some time, the metabolism will start. These 100 molecules, they will be metabolized to 90, then 80, then 70. So this effect will keep on decreasing. Now will it stop here? No, it will not stop here, because when it is metabolized to less than 50, so when the 49 molecules of adrenaline remains, remember they cannot act on alpha 1 now, but all 49 can act on beta 2. And when beta 2 is stimulated, it will result in vasodilation. So the BP falls. So this fall is due to beta 2. But these 49 will also be metabolized. So from 49 they become 40, 30, 20. So this effect will also start decreasing. And when they become less than 10, even beta 2 will not be stimulated, BP will come back to normal. So that means when we give adrenaline by IV route in high dose, there will be two phases in the response. First the BP increase, then the BP decrease. So initial increase in BP is due to alpha 1, later on fall in BP is due to beta 2. This is known as biphasic response of adrenaline. Biphasic response means first BP increase, then BP decrease. Clear? Now suppose we give adrenaline high dose, and before that we have already given alpha blocker. So we give high dose of adrenaline with alpha blocker, what will happen? So first thing what will happen is when we give 100 molecules of adrenaline with alpha blocker, so this increase in BP cannot come because alpha 1 is already blocked. So right from the beginning the BP will start decreasing. BP will start decreasing. Now second thing, will this decrease be only till this place? No, the BP will be more reduced. The decrease will be exaggerated because this decrease was caused by 49 molecules. But this will now all 100 are acting on beta 2. They cannot act on alpha 1. So two things we note. One, biphasic response is absent, only fall occurs. Second, this fall is exaggerated. So normally when we give adrenaline high dose, we will expect that BP will first increase. But when we give adrenaline with alpha blocker, only decrease occur. So opposite to what we were expecting has happened, and this opposite is known as reversal. So this phenomenon is called as vasomotor reversal. Vasomotor means on the muscle of the blood vessel effect is reversed. Instead of vasoconstriction, vasodilation occur. It was first noted by scientist Henry Dale. So it is called vasomotor reversal of Dale. Clear? Now coming to most important question. We never give adrenaline intravenously. Then what is the use of reading this phenomenon? We will not give IV adrenaline. Then why to talk about this? The reason is we do not give intentionally, but in patients with pheochromocytoma, which is tumor of adrenal medulla, large amount of adrenaline can be secreted into blood. So if large amount of adrenaline is secreted into blood, means it will be stimulating both alpha 1 and beta 2. But as alpha 1 is predominant, so the effect is this. So patient of adrenaline secreting pheochromocytoma has very high BP. Normally when the BP is high, we will give alpha blocker to reduce the BP. So in this patient, if we give alpha blocker, now what will happen is vasomotor reversal will occur. Because high dose adrenaline is present, we have given alpha blocker. So instead of BP becoming normal, the BP will fall very low and the person will develop severe shock and the person can die because of this. So important thing is if there is adrenaline producing pheochromocytoma, only alpha blockers can be very dangerous because they can result in vasomotor reversal of Day. That is the clinical importance to know about vasomotor reversal of Day. Clear? In patients of pheochromocytoma, there is excessive amount of adrenaline which can come into the blood. So vasomotor reversal comes here. Clinically important is at this point. So we'll try to understand first. Pheochromocytoma is a tumor of adrenal medulla. So there may be two type of patients. One in which the tumor is predominantly secreting adrenaline. Second in which the tumor is predominantly secreting noradrenaline. So two type of patients are there. Now in both the cases, whether it is adrenaline producing or noradrenaline producing tumor, both are sympathetic substances, both will cause vasoconstriction, both will stimulate the heart, so BP increases. So in both cases the blood pressure will be high. So adrenaline containing tumor also, noradrenaline containing tumor also, the BP is high. Suppose the person is having blood pressure of 180 here, 180 here. And we know adrenaline stimulate alpha 1, alpha 2 and beta, noradrenaline stimulate alpha 1, alpha 2 and beta 1, and adrenaline A for all stimulate all the receptors. In both the cases, the BP is high, and we know the predominant reason why BP is high is stimulation of alpha-1 receptor. It causes vasoconstriction, BP increases. So we will tend to block alpha-1 receptor, so the BP should decrease. So if we give alpha blocker to a noradrenaline producing tumor, so it will block the extra vasoconstriction caused by alpha-1, and blood pressure will come back to normal around 120. So there is no problem. We can use alpha-1 blockers in noradrenaline producing tumor. But if we try to do same thing here, we try to give alpha-1 blocker in adrenaline producing tumor, what will happen? Yes, now the vasomotor reversal will occur and the blood pressure will not become 120, rather it will reach the 20 or 10. So person will develop severe hypotension and the person will die. Yeah? So this is the important thing, that if a person is having adrenaline producing pheochromocytoma, only alpha blocker is dangerous. So only alpha blocker should not be given to patient producing adrenaline primarily. Clear? Now question is, in which out of these two pheochromocytomas we can give only beta blocker? In none of them. Reason being, in this person the BP is 180, not 220, 230, because the endogenous adrenaline is stimulating beta 2, and that beta 2 is causing vasodilation, and that decreases the BP slightly. So if we block beta 2, so that extra vasodilation caused by beta 2 is stopped, and the blood pressure from 180 will become 220, and the person can develop cerebral hemorrhage. The blood vessels in the brain may rupture. So beta blocker alone, they are contraindicated in every patient of pheochromocytoma. Okay. So what we discussed so far is, alpha blocker alone is contraindicated in adrenaline producing tumor. Beta blocker alone is contraindicated in both adrenaline producing as well as noradrenaline producing tumor. So the question is then, how to manage the hypertension in adrenaline producing pheochromocytoma? We cannot give alpha blocker, we cannot give beta blocker. How we can manage is, we will give alpha plus beta blocker. Remember, vasomotor reversal of Dale was occurring because there was unopposed beta 2 action. When we block alpha-1, only beta 2 is stimulated, that cause vasodilation, BP decreases. So if we block that beta also, so vasomotor reversal will not occur. Or we can say we have reversed the reversal, re-reversal will occur. So alpha plus beta blocker should be given in adrenaline producing tumor. Okay? So if we summarize what we have discussed, we have adrenaline producing tumor, we have noradrenaline producing tumor. So three type of drugs: alpha blocker alone, beta blocker alone, and alpha plus beta blocker. So we discussed alpha blocker alone is contraindicated in adrenaline producing tumor. Otherwise, vasomotor reversal of tail can occur. On the other hand, alpha blocker alone can be used in noradrenaline producing tumor, no problem. But on the other hand, beta blocker alone are contraindicated in both type of tumors. Whereas alpha plus beta blocker, they can be given in both of them. And in fact, for adrenaline producing tumor, the only treatment is combination. So this is all about the catecholamine group of sympathomimetic drugs. So the last group of sympathomimetic drugs remaining are non-catecholam. Now non-catecholamines will discuss according to the receptors on which they are working. First is the drug stimulating alpha-1 receptors. First of all, we have a drug called as phenylephrine. Phenylephrine. It stimulates alpha-1 receptors and it is mainly used as eye drops. So what is the effect of alpha-1 receptor in the eye? Yes, it causes mydriasis. So phenylephrine is used for mydriasis. Now do you remember which other drug we discussed that cause mydriasis? Yes, anticholinergic drugs cause mydriasis. So what is the difference between anticholinergic drug and phenylephrine in the eye? The difference is anticholinergic drugs cause mydriasis as well as cycloplegia, whereas phenylephrine cause only mydriasis, no cycloplegia. So that is very important to remember. Anticholinergic drugs cause both cycloplegia and mydriasis, whereas phenylephrine cause only mydriasis, no cycloplegia. Now another drug which stimulate alpha-1 receptors, these include methoxamine, mephentermine, and midodrine. Methoxamine, mephentermine, and midodrine. These drugs are mainly used for effect on the blood vessels. And what is the effect of alpha-1 on the blood vessel? It causes vasoconstriction, so BP will increase. And in which condition we will like to increase BP? We will like to increase BP in hypotension or shock. So these drugs, they are used for treatment of shock or hypotension. Then we have third group of drugs which stimulate alpha-1 receptors. These include xylometazole, oxymetazole, and nefazole. These all drugs stimulate alpha-1 receptors and they are given as nasal drops. Obviously, they will be used for treatment of nasal congestion. So these drugs are used as nasal decongestants. They are used to open the blocked nose. So we have three types of drugs acting on alpha-1 receptors. The drug can be used as eye drops, which is phenylephrine. The drug can be used as nasal decongestant. These are metazoline derived drugs. And third, we can use a drug to produce vasoconstriction to treat the shock like methoxamine, mephentermine. So that is all important about the alpha-1 receptors. Now coming to drug stimulating alpha-2 receptors. The drug stimulating alpha-2 receptors are clonidine and methyl-dopa. Clonidine and methyl-dopa. And we discussed the function of alpha-2 receptor was. It was acting like a brake. That means it was stopping the sympathetic activity. So when we give clonidine or methyl-dopa, they will stop sympathetic activity. So what will happen to blood pressure? The blood pressure will decrease. So these drugs, they are used to decrease blood pressure. That means used for treatment of hypertension. So clonidine and methyl-dopa, they are used for treatment of hypertension. Then lastly, we have drug stimulating beta-2 receptors. Remember, we do not have a non-catecholamine which acts on beta-1 receptors. So on beta-1 receptors, mainly we have catecholamines like dopamine, dobutamine like drugs. Now drug stimulating beta-2 receptors, the examples are salbutamol, terbutalin, salmeterol, and formoterol. They stimulate beta-2 receptors, and stimulation of beta-2 receptors result in bronchodilation. So these are given by inhalational route and they are used in treatment of bronchial asthma. Inhalational route, they are used in treatment of bronchial asthma. Now, more details about these will cover in respiratory system. We have another drug which stimulates beta-2 receptors. These are ritodrine and isoxsuprine. They also stimulate beta-2 receptors, but they are mainly used for their action on the uterus. Mainly used for their action on the uterus. So what is the effect of stimulating beta-2 on uterus? Yes, it relaxes the uterus. So these drugs are used as tocolytic drugs for treatment of preterm labor. So they used to delay the labor pains used for preterm labor. The next group of non-catecholamine can be beta-3 agonist, and the drug which stimulates beta-3 receptor is mirabegron. Beta-3 is primarily present on the adipose tissue and on the urinary bladder. Okay? So mainly on the urinary bladder, the drug is working. So beta-3 relaxes the bladder. So the drug which stimulates beta-3 will relax the bladder, so it can be used in overactive bladder. So mirabegron is used for overactive bladder. It relaxes the bladder and it will secrete the overactive bladder. And from the name you can remember, in Hindi if you study, the name look like Mera bladder gone, Mera background, Mera bladder gone. So bladder has relaxed. So that is beta 3 agonist. Clear? Our next topic is now autonomic nervous system. So autonomic nervous system, we all know it consists of two main parts, sympathetic system and parasympathetic system. Basically, autonomic nervous system is efferent branch of central nervous system. That means it originates from the brain and spinal cord only. So starting with the basic architecture, this is brain, this is spinal cord. ANS originate from the brain and spinal cord. The fibers which originate from the brain, that means cranial portion and sacral portion of spinal cord. So craniosacral outflow, this is parasympathetic system. Whereas the fibers which originate from the thoracic or lumbar region of spinal cord, thoracolumbar outflow, it is sympathetic system. So if you get confused which is sympathetic, which is parasympathetic, you can easily remember. Just like we study clinical subjects and paraclinical subjects. Clinical subjects are mean and paraclinical, they are sideways. So same here, the central one, thoracolumbar, is sympathetic, whereas above and below is para. So thoracolumbar is sympathetic and craniosacral is parasympathetic. Now after the origin, they will form a connection in the ganglion. In case of parasympathetic system, the ganglion is called parasympathetic ganglion, whereas in sympathetic system it is sympathetic ganglion. Now one thing which is clear in the diagram, that in case of sympathetic system, ganglia is near the spinal cord, whereas in case of parasympathetic system, ganglia is near the organs, or we can say away from the CNS. So based on the location of ganglia, the size of fibers differ. The preganglionic fiber are longer in parasympathetic system and postganglionic are small, and it is opposite in case of sympathetic system. So if you forget this also, you can easily remember, when we have sympathy with someone, we will keep the person close to us. So in case of sympathetic system, the ganglia is close to spinal cord. So preganglionic fibers are small in sympathetic system and postganglionic are longer. Now first fiber has to transfer the information to second fiber. For that, it will release a neurotransmitter, and the neurotransmitter released at all the preganglionic fibers is same, which is acetylcholine. Acetylcholine is the neurotransmitter secreted by all preganglionic fibers, and these will stimulate the receptor present on the postganglionic fiber, and the receptor is also same everywhere, it is NN. NN, as we discussed earlier also, it is junction of nerve and nerve. So NN receptor is present on the ganglia. So preganglionic fibers secrete acetylcholine that will stimulate the NN receptor present on the postganglionic fiber. Now second fiber get the information and it will take this information inside the organs. So it may take it in the eye, it may take it in the brain, or it may take it into the any organs. So inside the organs the same thing will happen. Now the postganglionic fiber will secrete a neurotransmitter which will stimulate the receptor present inside the organs. Now this neurotransmitter is different in sympathetic and parasympathetic system. Preganglionic fibers secrete same neurotransmitter, but postganglionic fibers secrete different neurotransmitter. In case of parasympathetic system, this is also acetylcholine. Parasympathetic system, postganglionic fibers also release acetylcholine. So that's why parasympathetic system is also called as cholinergic system, because mainly acetylcholine works. Whereas in case of sympathetic system, this mainly secrete noradrenaline. So that's why sympathetic system is also called as adrenergic system. Now mostly it is noradrenaline, but there are some exceptions. Most prominent exception you need to remember is sympathetic supply, which is to sweat glands. Sympathetic fiber going to sweat glands secrete acetylcholine. Most of the sympathetic postganglionic fibers secrete noradrenaline, but sympathetic fiber to the sweat glands secrete acetylcholine. So sweat glands have sympathetic cholinergic supply. So this is the basic architecture. Quickly revising. Thoracolumbar is sympathetic, craniosacral is parasympathetic. Number 2, location of the ganglia. It is near in the sympathetic system, away in the parasympathetic system. So accordingly the size of the fibers. Neurotransmitters. All preganglionic fibers secrete acetylcholine, but postganglionic fiber in case of parasympathetic system secrete acetylcholine, whereas in sympathetic system they secrete noradrenaline. Exception, in sympathetic system to sweat glands, the postganglionic fibers secrete acetylcholine. The next important thing is functions of these systems. Remember, parasympathetic system and sympathetic system have opposite function. That means if one stimulate, the second will inhibit at most of the places. So, and you can remember very easily, we know sympathy is related to heart. So if we see heart, sympathetic system will stimulate the heart. Parasympathetic is opposite, it will depress the heart. So sympathetic system will stimulate the heart, parasympathetic will depress the heart. At all other places apart from heart, the action is opposite. That means parasympathetic will stimulate, sympathetic will inhibit. You can easily remember this thing. Sympathetic system stimulates the heart but relaxes most other places. Parasympathetic system depress the heart but stimulate most other places. It will become more clear if we discuss what is the meaning of other places. Like if we talk about bronchus, parasympathetic stimulate. Stimulate means bronchoconstriction. Sympathetic opposite, bronchodilation. If we talk about GIT, parasympathetic stimulate. Stimulate means it will increase the motility. It will increase the secretions. So that will predispose to diarrhea. Sympathetic opposite, it will predispose to constipation. In case of bladder, urinary bladder, parasympathetic will stimulate. Stimulate means it will contract the detrusor muscle. That will lead to increase in urine outflow. Whereas sympathetic opposite, it will decrease the urine outflow. In case of glands, parasympathetic stimulate. Stimulate means it will increase the watery secretion. Sympathetic opposite, it will decrease the watery secretions. In the pupil, parasympathetic stimulate. Stimulate means it will contract the pupil. Contraction of pupil is called meiosis. Parasympathetic system cause meiosis. Sympathetic opposite, it will lead to dilation of pupil called mydriasis. So sympathetic system will dilate the pupil, parasympathetic will contract the pupil. If you again forget, you can easily remember. Mydriasis is a longer name, means pupil is long, that means dilated. Meiosis is a small name, means pupil is contracted. So basically you can remember, sympathetic system stimulates the heart but relaxes most other places. Parasympathetic system depresses the heart but stimulates most other places. This is the basic structure and functions of autonomic nervous system, sympathetic and parasympathetic system. So with this basic information, now we can start the system separately. We will start from the parasympathetic system. Quick recap. Parasympathetic system originate from craniosacral. Craniosacral. Cranial nerves 3, 7, 9 and 10, they are parasympathetic. That means oculomotor, facial, glossopharyngeal and vagus. Whereas sacral it is 2, 3 and 4. So parasympathetic system originate from these areas. Then they will form a connection in the ganglion. Ganglion is away from the spinal cord. So that means near the organs. So preganglionic fiber is long, postganglionic fiber is small. Then neurotransmitter by preganglionic as well as postganglionic fiber is acetylcholine. So if we want to understand about parasympathetic system, first we need to understand about acetylcholine. So first of all, how acetylcholine is produced and how it works we need to know. Then we can discuss the system in detail. So acetylcholine is stored here in the vesicles, preganglionic fibers. The first question is, from where this acetylcholine comes? The answer is, acetylcholine is formed by this neuron. Remember, by definition, neurotransmitter has to be synthesized in that neuron. If it is synthesized somewhere else and comes into the neuron, then it cannot be called as a neurotransmitter. And we know acetylcholine is a neurotransmitter, so it must be synthesized in the neuron itself. But for synthesis, we can take raw material from outside, and raw material in case of acetylcholine is choline. The first step is choline will enter inside. It is converted to acetylcholine, and that will be stored in the vesicle. Whenever nerve impulse comes, acetylcholine will be released. Then it will work on the receptors. So parasympathetic action will come. Quick recap again. Parasympathetic action means if it is working in the heart, it will depress. If it is working at some other places, it will stimulate. Now we know that no substance keep on working forever. So we have to stop the action of acetylcholine also, and that is done by metabolism. The action of acetylcholine is stopped by acetylcholine esterase. Acetylcholine esterase metabolize acetylcholine, that will terminate the action. Now among all the steps which we have discussed, the slowest step or the rate limiting step, it is the first step, that means uptake of choline. Uptake of choline is the slowest step in the parasympathetic system. Now finally we know that the action is due to stimulation of these receptors, and these receptors are stimulated by acetylcholine present in the synapse. So if we manipulate the level of acetylcholine in the synapse, we can change parasympathetic activity. That means if a drug increases acetylcholine in the synapse, it will increase parasympathetic action. If a drug decreases acetylcholine in the synapse, it will decrease parasympathetic action. And what drugs can do so? We have three drugs. Number one, which inhibit entry of choline, rate limiting step. Number two, which inhibit the entry of acetylcholine in the vesicle. And number three, which inhibit release of acetylcholine. Now if we see choline, if it do not come inside, then acetylcholine will not be formed. So there will be less parasympathetic action. And this is done by a drug called hemicolinium. Hemicolinium, and from the name you can remember this drug. Divide the drug into hemicholine. Hemi means half choline. Hemi is half choline. So only half of choline, and again you can see the name says inium. Inium means coming inside. So only half of choline will come in. When only half of choline is coming inside, half acetylcholine is formed, so half action will come. So it will decrease the parasympathetic activity. Number two drug, it inhibits the entry of acetylcholine in the vesicle, and the name of the drug is visamicol. Visamicol. This also you can remember, but you need to study the name in Hindi. So in Hindi you can study, it is saying that vesicle में choline नहीं आएगा. Vesicle में choline नहीं आएगा. So vesicle will not contain acetylcholine, so that will decrease the parasympathetic activity. On number three action, we can inhibit the release of acetylcholine, and that is done by a drug called as botulinum toxin. Botulinum toxin. Botulinum toxin. So again you can remember this also, that this structure of a neuron, it look like a bottle. You see, this structure of the neuron look like a bottle. So if we hold the bottle from below, nothing will leak out. So botulinum toxin, the name says bottle. So it will prevent the leakage from the bottle. That means acetylcholine will not leak. So when it do not come into the synapse, action will not come. So the three drugs we discussed, hemicolinium, half of choline comes in. Visamicol, vesicle में choline नहीं आएगा. And botulinum toxin inhibit the release from the bottle. So all three drugs have same action, that means decrease parasympathetic activity. Then we have number four drug, which inhibit acetylcholine esterase. Example is physostigmine. Physostigmine. So if a drug inhibit acetylcholine esterase, then acetylcholine cannot be broken. So there will be more acetylcholine in the synapse. So it will produce more parasympathetic action. So physostigmine is opposite to other three drugs we have discussed. So physostigmine will increase parasympathetic activity. Next thing is, finally the acetylcholine will work on these receptors. So if we give a drug which can stimulate these receptors, that will increase parasympathetic activity. If we give a drug which block these receptors, that will decrease parasympathetic activity. So to remember about those, we need to understand about receptors first. What are the receptors of acetylcholine? Where they are normally present, what they normally do, then we can easily know the effect of drugs on those receptors. So now we will move to receptors of acetylcholine. Now receptors of acetylcholine are broadly of two types. One are called nicotinic, they are written as N, and second are called muscarinic, they are called M. Nicotinic and muscarinic. Now nicotinic receptors are further of two types, NN and NM, and muscarinic receptors are of 5 types, M1 to M5, but mainly we have 3 receptors, M1, M2 and M3. Now you can easily remember NN is nerve and nerve. We discussed NN is present at junction of 2 nerves, and junction of 2 nerves we discussed is present in ganglia. On which ganglia nicotinic receptors NN receptors are present? Sympathetic or parasympathetic? Yes, they are present in both the ganglia. All the ganglia contain NN receptors. Then NM is neuromuscular junction. So it is present at neuromuscular junction. So when we stimulate NM receptors, the muscle will contract. But you need to remember one special point about NM receptors. It is that they require optimal stimulation for the muscle to work. That means if NM receptors are stimulated less than required, obviously there will be muscle weakness. But if NM receptors are stimulated more than required, even then the muscle weakness will occur. So NM receptor require optimal stimulation for proper functioning of muscles. In both understimulation and overstimulation, there will be muscle weakness. Now coming to M1, M2 and M3 receptors, muscarinic receptors. M1 is present in stomach. And we know parasympathetic system stimulate everything except heart. So M1 will stimulate the stomach, and there is main secretion in the stomach as hydrochloric acid. So M1 will increase the acid secretion in stomach. And which disease occur due to more acid in the stomach? Yes, it is peptic ulcer. So we can give M1 blockers for treatment of peptic ulcer. Now M2 is present in heart. So when we stimulate M2, it will depress the heart. So that can result in bradycardia. On the other hand, M2 blockers can lead to tachycardia. Then M3 is present at all other places, like M3 is present in the bronchus, in the GIT, in the bladder, in the glands, in the pupil. So everywhere else we have M3 receptors. And action of M3 we already know. Stimulation of M3 will result in bronchoconstriction, diarrhea, increased urine outflow, increased watery secretions and meiosis. So all these are actions of M3 receptors. And again you can remember these also, but again you need to study in Hindi. So you can remember पहले खाओ पियो, फिर दिल लगाओ, बाकी काम बाद में. पहले खाओ पियो means M1 in stomach, फिर दिल लगाओ means M2 in heart, and बाकी काम बाद में means M3 present at rest all places. So we have remembered the location of these receptors, and the actions we already know, that in the heart they will inhibit the heart, but in all other organs they will stimulate. So we have remembered the location and action of different parasympathetic receptors. So now we can safely go to drugs acting on these receptors. Now drugs acting on parasympathetic system are divided into parasympathomimetic drugs and parasympatholytic drugs. So if a drug stimulates the parasympathetic system, it is called mimetic. If a drug blocks the parasympathetic system, it is called parasympatholytic. So we will start from the parasympathomimetic drugs. Now parasympathomimetic drugs are divided into directly acting drugs and indirectly acting drugs. directly acting and indirectly acting drugs. Now directly acting drug means this will directly act on any of those 5 receptors. That means NN, NM, M1, M2 and M3. It will directly stimulate any of those receptors. Whereas indirectly acting drug means the drug will not act on receptors, but it will increase acetylcholine, and acetylcholine will stimulate the receptors. And how to increase acetylcholine we discussed? Yes, we can increase acetylcholine by inhibiting its metabolism. That means indirectly acting drugs are basically acetylcholine esterase inhibitors. Acetylcholine esterase inhibitors. So we'll start from the directly acting drugs. Directly acting drugs, we have main 5 drugs to discuss. One is pilocarpine. Second is bethanicol. Third is methacholine. And fourth is carbachol. So pilocarpine, bethanicol, methacholine and carbachol. The first question is, we need to remember that these are parasympathetic drugs or these are cholinergic drugs, and that you can remember from the name itself. Because they are cholinergic drugs, they contains acetylcholine in the name. So you can find that bethanicol contains a chol in the name, that means acetylcholine. Methacholine contains a chol, acetylcholine. Carbachol contains a chol, acetylcholine. Pilocarpine do not contain. Yes, it also contains, just you need to study backwards, a chol, acetylcholine. That means if a drug name contains a chol, means the drug is cholinergic or parasympathetic drug. Now the MCQ about these drugs you can answer by using the first letter of the drug. The first letter of the drug you can find. Pilocarpine start with P. P means pupil. So pilocarpine mainly act on pupil. And what it will do to pupil? It will cause meiosis. It is a parasympathetic drug. And meiosis is required for which condition? Meiosis is required for angle closure glaucoma. So pilocarpine is used in closed angle glaucoma or angle closure glaucoma. Then bethanicol, the name starts from B. B means bladder. Bethanicol mainly works on bladder. So what it will do to bladder? It will contract the bladder. Contract the bladder. And when bladder contracts, outflow increases. So in which condition we will want to increase the urine outflow? Yes, we are using them for atonic bladder. So when the bladder has low tone, means bladder is not able to contract, we can give bethanicol. It will contract the bladder, urine outflow increases. Then methacholine start with M. M for myocardium. Myocardium. So methacholine is used for myocardium, that means heart. So what it will do to heart? Methacholine will depress the heart because parasympathetic system depress the heart. So it can be used for tachycardias. So methacholine can be used in tachyarrhythmias. So we have discussed 3 drugs so far. P for pilocarpine, P for pupil, B for bethanicol, B for bladder, M for methacholine, M for myocardium. Now quickly revising, which receptor is present on pupil? On pupil we have M3 receptors. So pilocarpine work on M3. Which receptor is present on bladder? M3 receptors. So bethanicol work on M3. Which receptor is present on myocardium? It is M2 receptor. Methacholine work on heart, M2 receptors. Now what is we find is the 3 drugs we have discussed so far, they are all working on muscarinic receptors. So first 3 drugs, they are not working on nicotinic receptors. So carbachol you can remember, C for carbachol, C for common action. Common action means carbachol can work on both nicotinic and muscarinic receptors. Carbachol can stimulate both nicotinic and muscarinic receptor, and that is commonly asked in the MCQs. Which of the following drug has maximum nicotinic activity? The answer will be carbachol, because other 3 drugs do not act on nicotinic. Other 3 act only on muscarinic, whereas carbachol act on both nicotinic and muscarinic. Recently, we have developed a new drug which is called as savimeline. Savimeline. This drug stimulates the M3 receptors, particularly in the glands.
So what will happen when we stimulate M3 in the glands? Yes, secretions will increase. So cevimeline, it is used for treatment of xerostomia. Xerostomia means dry mouth. Yeah? Particularly in patients which have this problem called as Sjogren syndrome. Sjogren syndrome is a condition which is characterized by dryness. Glands are not able to work properly. So cevimeline is used to treat xerostomia in Sjogren syndrome.
This is the only thing you need to remember about directly acting drugs. Now we'll move to indirectly acting drugs. Acetylcholinesterase inhibitors. Now inhibitors of this enzyme, they may be reversible inhibitors, they may be irreversible inhibitors. The two types of acetylcholinesterase inhibitors, reversible and irreversible. We do not like to inhibit anything normal permanently. So irreversible inhibitors are not used clinically, whereas reversible inhibitors are very commonly used clinically. So first of all, we'll start with the reversible drugs, and later on we will discuss irreversible drugs. Now reversible acetylcholinesterase inhibitors are further divided into lipid soluble drugs and water soluble drugs. Lipid soluble and water soluble. So lipid soluble drug, the main example is physostigmine. Whereas water soluble drug main example is neostigmine.
You need to remember two important differences between physostigmine and neostigmine. The first difference is physostigmine is natural. It is obtained from a plant. So it is a natural product, whereas neostigmine is a synthetic product. But second, which is more important, we discussed already, physostigmine SO means it is soluble. Physostigmine is lipid soluble, whereas neostigmine it is water soluble. Now why they are lipid or water soluble? The basic concept you can understand. Physostigmine is a tertiary amine, whereas neostigmine is a quaternary amine. What is the meaning of these is, if you see ammonia, what we write NH3, it is ammonia. So that means 3 atoms are attached to nitrogen. But in ammonium ion, when we attach one more atom, it becomes NH4 positive. A positive charge comes. So that means when 3 atoms are attached, it is a tertiary. So tertiary amine is non-ionized. Whereas when 4 atoms are attached, it is quaternary. And quaternary amine means it is ionized. So physostigmine is a tertiary amine. It is non-ionized, and we know non-ionized are lipid soluble, they can cross the membranes. Whereas neostigmine is quaternary amine. It contains 4 atoms. Quaternary amines are ionized, and because they are ionized, they are water soluble, so they cannot cross the membranes. So physostigmine is a tertiary amine, whereas neostigmine is quaternary amine. Okay.
So first of all, which is lipid soluble, which is water soluble, again you can remember from the name itself. Physostigmine, the name itself says soluble. It is lipid soluble. Physostigmine is lipid soluble. Whereas neostigmine says it is not soluble. Normally we talk about lipid solubility in pharmacology. So physostigmine is soluble, neostigmine is not soluble. Now what is the importance of lipid or water solubility? We have to discuss that. We discussed in general pharmacology that a lipid soluble drug can cross the membranes. Water soluble drug cannot cross the membrane. So which membranes we are talking about? We are talking mainly about 3 membranes. One are the GIT membrane. Second are blood-brain barrier. And third is blood corneal membrane, or we can say entry of drug in the eye, action on the pupil. So physostigmine can cross all the membranes. Neostigmine cannot cross any of these membranes. So that means physostigmine can be absorbed from GIT. So it can be given orally. Whereas neostigmine like drugs are commonly given by injection. Physostigmine like drugs can cross blood-brain barrier. So they can enter the brain, produce the effect there. Neostigmine will have no central effects. Physostigmine can cross the corneal membrane and produce effect on pupil. So we can use in glaucoma, whereas neostigmine will not have any effect on the pupil. That is the basic difference. So we'll start from the lipid soluble drugs and then we'll discuss neostigmine, that means water soluble drug. So lipid soluble drug physostigmine, we discussed it can cross the corneal membrane. So it can be used in angle closure glaucoma. Second thing, physostigmine can enter the brain. In the brain, very, very important use of physostigmine is it can be used for atropine poisoning. In fact, physostigmine is a drug of choice for atropine poisoning. Now, first of all, we need to understand what is atropine. Atropine is antagonist of muscarinic receptors. It blocks all the muscarinic receptors M1, M2, M3, all of them. Physostigmine is a blocker of, atropine is a blocker of muscarinic receptors. Remember, it blocks only muscarinic receptor, it do not block nicotinic receptors. Another important thing, atropine can cross blood-brain barrier. So when atropine poisoning occur, there will be blockage of these receptors in the brain as well as outside the brain. So when we want to treat the poisoning, we have to stimulate these receptors in the brain as well as outside the brain. And for stimulating these receptors, we require acetylcholine. And for increasing acetylcholine, we will want to inhibit its metabolism. That means we will want to give acetylcholine esterase inhibitor. And for treating the atropine poisoning, we will want a drug which can also enter the brain. So physostigmine is such a drug, it is a lipid soluble drug. 50% of the drug enter the brain. So it will inhibit acetylcholine esterase in the brain and treat the poisoning there. And 50% of the drug remain outside the brain and that will treat the peripheral symptoms of atropine poisoning. So physostigmine can treat all the symptoms of atropine poisoning. That's why physostigmine is a drug of choice for atropine poisoning. Physostigmine is a drug of choice for atropine poisoning. So two main uses of physostigmine. One, it is used for angle closure glaucoma. Second, it is drug of choice for atropine poisoning. Now, in the brain, there is another disease. First of all, this is brain. It contains an area normally present in all of us. This area is called basal nucleus of Maynard. Basal nucleus of Maynard. This area contains plenty of cholinergic supply, means large number of cholinergic neurons are available in this area, or in simple language we can say all the function is done by acetylcholine here. And the main function of basal nucleus of Maynard, you can remember M for Maynard, M for memory. This area is involved in acquiring and retaining memory. Now after birth, the neurons do not divide. So that means at the time of birth we have maximum number of neurons. But some of the neurons die with age. So in late ages, in old age people, many neurons die. So if sufficient number of neurons die in this area, so it will not be able to perform its function. So that means it can lead to loss of memory. So that loss of memory technically is called as dementia. And because it is age related, it is called senile dementia. So in elderly people, there may be senile dementia. The other name of senile dementia is Alzheimer's dementia. Alzheimer's dementia. So senile dementia or Alzheimer's dementia, it is loss of memory occurring in old age patients due to degeneration of cholinergic neurons in basal nucleus of Maynard. So what we want in this condition is we want to improve memory. And we can improve memory by increasing acetylcholine in the brain. And for increasing acetylcholine in the brain, we will want acetylcholine esterase inhibitor. But because we want in the brain, the drug should cross the blood-brain barrier. And for crossing the blood-brain barrier, the drug must be lipid soluble. So we will want a lipid soluble acetylcholine esterase inhibitor in the brain. And the drug which is lipid soluble acetylcholine esterase inhibitor we discussed so far is physostigmine. So can we use physostigmine in Alzheimer's disease? Answer is no. Reason? So when we give physostigmine, we discussed physostigmine is acetylcholine esterase inhibitor. 50% of this remain in the periphery. 50% of this enter the brain. So physostigmine, 50% which enter the brain will improve the memory, which is good for Alzheimer's disease. But 50% which remain in the periphery, it will stimulate M1, M2 and M3 receptors. Remember, M1 is present in the stomach. So physostigmine will stimulate M1, which will lead to acidity. It will stimulate M2, which will lead to bradycardia. It will stimulate M3 in the GIT, which will lead to diarrhea. It will stimulate M3 in the bladder, which will lead to urine outflow. So that means physostigmine will improve the memory, but person will use all the memory in the toilet. So there will be no use of such a memory. So although physostigmine is effective in Alzheimer's disease, but because of peripheral side effects, we do not use physostigmine. So what is the solution to this? The simple solution is we want acetylcholine esterase inhibitor only. We want a lipid soluble drug only, but we want such a drug which has almost 100% entry in the brain. So that means we want a highly lipid soluble drug which almost all enter the brain, do not remain outside. So these peripheral side effects will not come. And we found such a drug, and that drug we found was tacrin. Tacrin. It is a lipid soluble acetylcholine esterase inhibitor. So it will improve the memory without causing the peripheral side effects. And due to this reason, tacrin was the drug of choice for Alzheimer's disease for many years. Now why we have put was here is because even tacrin has some disadvantages. And the disadvantages of tacrin are, number one, it is very short acting. So we need to give several times a day. And number two, tacrin caused liver damage in some people. Tacrin was hepatotoxic. But because we did not have any alternative, so this was the drug of choice. But recently, we have developed new drugs which are effective and safe. And these drugs are preferred now. And these drugs are donepezil, rivastigmine, and galantamine. Donepezil, rivastigmine and galantamine. Like tacrin, these are acetylcholine esterase inhibitors. Like tacrin, these are reversible drugs. Like tacrin, these have 99% entry in the brain. But unlike tacrin, these are long acting. So they can be given once a day or maximum twice a day. And second, they are not hepatotoxic. So in simple language, they contain advantage of tacrin, but they do not contain disadvantages of tacrin. So because of this reason, they have now become the drug of choice for Alzheimer's disease. Donepezil, rivastigmine and galantamine, they are now the drug of choice for Alzheimer's disease. And you can remember them from my name. So these are remembered as Dr. Govind drugs, the drugs which are used to improve memory. Dr. Govind drugs. Donepezil, rivastigmine and galantamine, used to improve memory.
Another drug which is used in Alzheimer's disease is memantine. Memantine acts by a different mechanism. It acts by blocking the NMDA receptors of glutamate. So Alzheimer's disease, we have two main mechanisms by which we can treat it. One mechanism is to increase the level of acetylcholine in the brain by giving the drugs like donepezil. And second method is by blocking the NMDA receptors, which is done by memantine.
So this is all important points regarding the reversible acetylcholine esterase inhibitors, which are lipid soluble. So now we'll move to water soluble drugs. Water soluble drugs, main drug we discussed is neostigmine. Apart from neostigmine, we have some other drugs also like pyridostigmine. and adrophonium. All of them are reversible acetylcholinesterase inhibitors and they are water soluble. And because they are water soluble, they cannot cross membranes. So they have to be given by injection because they do not cross GI membrane. These drugs cannot enter the eye, so not effective in glaucoma. They cannot enter the brain, so they are not preferred in Alzheimer's disease. But the main advantage is they do not cross the blood-brain barrier. So that means whenever we want cholinergic action outside the brain, they will be preferred because they will not cause central side effects. And the major use of these drugs is myasthenia gravis. Major clinical indication is myasthenia gravis. Myasthenia gravis is autoimmune disease in which there is formation of antibodies against NM receptors. The receptors which are present at neuromuscular junction, antibody is produced against this receptor. So when the antibody bind to this receptor, now acetylcholine is not able to stimulate these receptors. So when NM receptors are stimulated less than required, it will lead to muscle weakness. So the main symptom in myasthenia gravis is muscle weakness, and the reason is formation of antibodies against NM receptors. So NM receptor is understimulated. But if you remember, if NM receptor is overstimulated, it also causes muscle weakness. So the disease in which they are overstimulated is called cholinergic crisis. So in cholinergic crisis, there is overstimulation of NM receptors. And this also leads to muscle weakness. The important thing, muscle weakness can occur in two opposite diseases. Myasthenia gravis, in which NM receptors are understimulated, and cholinergic crisis, in which NM receptors are overstimulated. And obviously the treatment of these two will be opposite. In myasthenia gravis, we will like to stimulate NM, and in cholinergic crisis, we will like to block NM. But the clinical feature is same. So first of all, we need to differentiate what the actual condition is. Only then we can so we want to differentiate whether it is myasthenia or cholinergic crisis. And for differentiation or for diagnosis of myasthenia gravis, the drug we prefer is adrophonium. So what we do is, a patient who comes with muscle weakness, suspected myasthenia gravis or cholinergic crisis, we give him adrophonium IV. Intravenous adrophonium is given. The special advantage of adrophonium is it is very short acting. Its action remains for less than 10 minutes. Adrophonium is very short acting. Action remains for less than 10 minutes. So person has come with muscle weakness. We have given IV adrophonium to this person. And when we give adrophonium, it will increase acetylcholine. When acetylcholine increases, NM is stimulated. And when NM is stimulated, what will happen in myasthenic patient? The condition will improve. So after giving adrophonium, if the condition improves for 10 minutes, the diagnosis is myasthenia gravis. But on the other hand, had the person is suffering from cholinergic crisis, then increase in acetylcholine will further stimulate NM receptors. So the condition will worsen for 10 minutes. So after giving adrophonium, we assess the person. If the condition start improving, it is myasthenia gravis. If the condition start worsening, it is cholinergic crisis. So we can diagnose. So can we use adrophonium for treatment? No, we cannot use because it is working only for 10 minutes. Treatment, we will want a longer acting drug. So neostigmine and pyridostigmine, they are used for treatment of myasthenia gravis. Whereas adrophonium is used for diagnosis of myasthenia gravis. And this test is called as adrophonium test.
Pyridostigmine is longer acting than neostigmine. Read carefully. It is pyridostigmine. Many times the examiner try to confuse by writing physostigmine. So one thing, pyridostigmine is longer acting than neostigmine. Second thing, both pyridostigmine as well as neostigmine, both of them apart from inhibiting the acetylcholine esterase, they also have direct NM receptor stimulating activity. They are direct agonist of NM receptors also. So this property may be beneficial in treatment of myasthenia gravis.
So now we have diagnosed and we have started the treatment with neostigmine. We start the treatment with neostigmine or pyridostigmine. Now how these drugs will work is, these drugs inhibit acetylcholine esterase. That will lead to increase in acetylcholine. When acetylcholine increases, it stimulates the NM receptors and that will improve the myasthenia gravis. Muscle weakness is improved. But the problem is, when acetylcholine increases, it also stimulates M1, M2, M3 receptors. And when these receptors are stimulated, the same side effects will come. That means acidity will occur, bradycardia will occur, diarrhea, urination will occur. So that means although neostigmine improve the muscle power, but person will use all that power in the toilet. So again, there is no use of such power. So what is the solution? Solution is, we want acetylcholine to work only on nicotinic receptors, not on muscarinic receptors. Do you know any drug which block only muscarinic, not nicotinic? Yes, it is atropine. So what we do is, we will give atropine with neostigmine. So when we give atropine, it blocks M1, M2 and M3 receptors. So neostigmine will increase acetylcholine and that will selectively work on nicotinic receptors only. So it will improve myasthenia gravis without causing the muscarinic side effects. So we use neostigmine plus atropine for treatment of myasthenia gravis. So this is the first use of cholinergic drug, neostigmine, or we can say water soluble drugs. There is another use. So first is myasthenia gravis. Then second use is cobra bite. Now when the snake cobra bites, the venom of cobra snake go to neuromuscular junction and blocks NM receptors. So venom will bind to NM receptors and block them. That will lead to muscle weakness. Now the problem is like myasthenia gravis. Symptom is like myasthenia gravis. So treatment is also like myasthenia gravis. So cobra bite, we will again use neostigmine with atropine. Same problem, same solution. So neostigmine plus atropine is used for myasthenia gravis and cobra bite. Now there are other conditions, particularly post-operative conditions called as post-operative paralytic ileus and post-operative urinary retention. Now, post-operative. Suppose we have to do some operation. Suppose we have to do some operation on the abdomen. So when we open the abdomen, in front we will find ileum. Loops of ileum are present. So we cannot see anything inside the abdomen unless we pick these loops of intestine and keep them on one side. Only then we can see anything inside. The problem is, whenever we touch the intestine, they stop working. They stop working. But after some time they recover. That's the reason that after any abdominal surgery, we keep the patient NPO. NPO means nil per oral. We do not give anything orally because GIT is not working. So when the GIT recovers, then we can give it orally. But sometimes they do not recover at all. So then we have to stimulate the ileum. And ileum contains which receptors? Yes, ileum contains M3 receptors. And for stimulating M3 receptors, we require acetylcholine. And for increasing acetylcholine, we can give neostigmine. So we can give neostigmine for post-operative paralytic ileus. It will increase acetylcholine, that will stimulate M3 receptors, and that will treat paralytic ileus. The question is, will you like to add atropine? The answer is no, because if we add atropine, it will block M3, then neostigmine will become useless. So in post-operative paralytic ileus, we will use only neostigmine, not atropine. Same condition is post-operative urinary retention. If during the operation we touch the bladder, it will stop working. If we want to stimulate the bladder, it also contains M3 receptors. And for increasing M3 stimulation, we want acetylcholine. And for increasing acetylcholine, we can give neostigmine. Now again without atropine, because if we give atropine, it will block M3, so it will become useless. So basically neostigmine like drugs have 4 uses. We can divide these users into nicotinic users and muscarinic users. Nicotinic users include myasthenia gravis and cobra bite. Here we want nicotinic action only. We do not want muscarinic action. So we add atropine to block that. Whereas muscarinic users include paralytic ileus and urinary retention. Here atropine will not be added because that will interfere with efficacy of these drugs.
Another condition where we can use neostigmine or pyridostigmine like drugs is for reversal of non-depolarizing muscle relaxants. So what is the concept here is, there are some drugs which are used to relax the muscles, like we have atracurium, pancuronium like drugs. What they do is they act by blocking the NM receptors. Remember, on the neuromuscular junction NM receptor is present. So they block the NM receptors. When NM receptors do not work, the muscles relax. And we know muscle relaxants are used during surgery. So now we have started a surgery, we have given a muscle relaxant, and surgery is over in half an hour or 1 hour or 1.5 hours. But the muscle relaxants, it keep on working for longer period, maybe 6 hours, 10 hours, 20 hours. So after the surgery is over, we want that muscle to work. So how will they work? If NM receptor is stimulated, and which substance stimulates the NM receptor? Acetylcholine. So for reversing the action of muscle relaxants, we need to increase acetylcholine. So we can use neostigmine or pyridostigmine. They inhibit acetylcholine esterase, that will increase acetylcholine, and when acetylcholine increases, it stimulates NM receptors and the muscles start working. Clear? The question is, will you like to give atropine with this? The answer is yes, because we want the nicotinic action, not muscarinic. If we do not give atropine, it will start stimulating the muscarinic receptors. So that will produce lot of side effects. So to stop these side effects, we usually add atropine also. Okay.
So this is about the reversible acetylcholine esterase inhibitors. So now we can move to irreversible drugs.
Irreversible acetylcholine esterase inhibitors. The drugs in this group include organophosphates and carbamates. Examples of organophosphates include drugs like malathion and parathion, which are most important. Apart from that, we have many other drugs like DFP, tabun, serine. These are called nerve gases. So many organophosphates are there, but be very careful. There is a drug called as andrine. Remember, andrine is organochlorine. It is not an organophosphate. So its treatment is totally different from organophosphate poisoning. And carbamates include carbaryl and propoxur. Now most of these drugs, they are used as insecticides and pesticides. So commonly they are used by farmers. The problem with these drugs is all of them, they are highly lipid soluble drugs. And what is the importance of lipid solubility? Yes, they can cross the membranes. And these are so much lipid soluble that they can even cross the membrane of intact skin. That means if they are touching the skin for a long time, they can be absorbed and go to blood. Like a farmer is spraying these drugs in the field, and during spraying, some of the drug touches the skin and that reach the blood because they are highly lipid soluble. Now when it reaches the blood, it will inhibit acetylcholine esterase permanently, irreversible. So when the acetylcholine esterase is inhibited, what happens?
When acetylcholine esterase is inhibited, it will lead to increase in acetylcholine. And when acetylcholine increases, it will stimulate M1, M2 and M3 receptors. Stimulant of M1 receptors will lead to acidity. Stimulation of M2 receptors will result in bradycardia. And when heart is working less, it will also lead to hypotension. Bradycardia and hypotension. Stimulation of M3 receptors in the eye will lead to meiosis. And in case of poisoning, the meiosis will be so severe that the pupil will look like a point. The condition called pinpoint pupil. Pinpoint pupil.
Pinpoint pupil is seen in very few conditions. So you should know important causes of pinpoint pupil, and you can remember that easily. Pinpoint pupil is seen in OP poisoning. We just discussed organophosphate poisoning. So you can remember that 2 from O and 2 from P. O means organophosphate and carbamate poisoning. Organophosphate and carbamate poisoning. And second O is opioid poisoning. Opioid poisoning like morphine poisoning. So pinpoint pupil may be seen in organophosphate poisoning and carbamate poisoning, but also in morphine poisoning. Then on P we have phenol poisoning. Phenol poisoning also can cause pinpoint pupil. The other name phenol is carbolic acid. So pinpoint pupil is also seen in phenol or carbolic acid poisoning. And the last P is pontine hemorrhage. Pontine hemorrhage. Hemorrhage in the pons area of the brain. So pinpoint pupil, it can be seen in OP poisoning. OP, O means organophosphate and opioid poisonings. P means phenol poisoning and pontine hemorrhage.
Then all these secretions will increase. In the gland, secretions will increase. The person will be sweating profusely. Tears will be coming from the eyes. Saliva will be drooling from the mouth. So all secretions increase tremendously. Then in the GIT there will be intractable diarrhea. There will be urinary incontinence. Urinary incontinence. There will be bronchoconstriction, which can lead to respiratory problems. So all these things will happen. And when all the receptors are present in the brain, when they are overstimulated in the CNS, the person will go to coma. So in case of organophosphate or carbamate poisoning, due to stimulation of muscarinic receptors, there will be acidity, bradycardia, hypotension, pinpoint pupil, increase in secretions, diarrhea, urinary incontinence, respiratory problems and coma. Now, most important among these to remember are these two symptoms. Pinpoint pupil with increase in secretions. Remember, no poisoning cause combination of these two symptoms. If both of them are present, you need not study anything else. The answer will always be acetylcholine esterase inhibitor poisoning. Pinpoint pupil plus increase in secretions. Now, why I am discussing like this is, once the question was asked in an exam that a farmer presented in emergency in comatose state with pinpoint pupil, with increase in secretions, with severe diarrhea, with urinary incontinence, with respiratory problem. The confusing point given was the heart rate of the farmer is 220 beats per minute and BP of the farmer is 210 by 100 beats per 100 millimeter of mercury. That means instead of decrease in BP and heart rate, there was increase in BP and heart rate. All other features were like that only. The question asked was, what is the diagnosis? So what will be the diagnosis? Diagnosis is still this poisoning only. Then what is the reason BP and heart rate should be low? Why they are high? The reason is when acetylcholine increases, it not only stimulates muscarinic but also nicotinic receptors. So it can stimulate NN and NM receptors. Now where NN is present? NN is present at junction of nerve and nerve. That means ganglia. So which ganglia they are present? Sympathetic or parasympathetic? Yes, they are present at both the ganglia. So when they stimulate the NN receptor of sympathetic ganglia, that can lead to tachycardia and hypertension. So it is that nicotinic symptom which can appear rarely. Remember, normally this feature do not come. The reason is NN receptor stimulation require very high dose as compared to stimulating any other receptor. So it is rarely possible, but it is possible. So that feature can come. Similarly, overstimulation of NM receptor will result in muscle weakness. Muscle weakness can occur. So these are the total symptoms that can occur in organophosphate or carbamate poisoning. There will be muscarinic symptoms, there may be nicotinic symptoms. Muscle weakness commonly occurs, but ganglionic stimulation rarely occurs. So from these features you can easily diagnose it is organophosphate or carbamate poisoning. Now we have diagnosed, so we need to treat, and we know most of the symptoms are muscarinic symptoms, M1, M2, M3. So to treat these symptoms, we will block muscarinic receptors. And which drug blocks muscarinic receptors? Yes, the answer is atropine. So atropine is a drug of choice for organophosphate and carbamate poisoning. Atropine is a drug of choice for organophosphate and carbamate poisoning. It is given by IV route. IV route. And we will keep on repeating atropine every 5 minutes. We repeat atropine every 5 minutes till signs of atropinization come. Signs of atropinization come. Signs of atropinization means these are signs which will tell that we have reached the effective dose of atropine. And the important signs of atropinization are, 3 signs are mainly checked. One is a decrease in secretions. The person is having profuse sweating. The person is having increase in secretions. So when we block M3, secretions will decrease. Second, there will be mydriasis. And third, there will be tachycardia, heart rate more than 100. So these are the 3 main signs of atropinization. Regarding MCQs, you need to remember decrease in secretions is most reliable sign of atropinization. Most reliable sign, or you can say most specific sign. Mydriasis is most commonly used sign of atropinization. So most commonly used sign is mydriasis, but most reliable is a decrease in secretions. Clinically, we check all 3. So we keep on giving atropine when all 3 comes. That means that we have saved our patient. So atropine is a drug of choice for organophosphate and carbamate poisoning. It can reverse all of these symptoms. The question asked is which symptom cannot be reversed by atropine? Remember, atropine can reverse all these, whichever is caused by M1, M2 and M3. But atropine cannot reverse this muscle weakness because atropine blocks only muscarinic but not nicotinic receptors. So atropine cannot reverse the muscle weakness. It can reverse all other symptoms but not muscle weakness. Now, yes. Remember, the name says they will reactivate the inhibited enzyme. Organophosphate and carbamates are irreversible inhibitor of acetylcholinesterase. Acetylcholinesterase cannot automatically work, but if we give these drugs, they can start working. And chemically, all of these drugs are oximes. And 2 main drugs we have in this category are prelide oxime, which is commonly written as PAM, and diacetyl monooxime, which is called DAM. PAM and DAM. And 2 important MCQs, in fact 3 important points you need to remember about these drugs. First and the most important thing to remember are oximes are not the drug of choice for organophosphate or carbamate poisoning. Drug of choice, if the question is asked, is atropine. Atropine is life saving. They cannot save the life. So atropine is drug of choice. They are enzyme reactivators. Second thing you need to remember is triple O. Triple O means oximes are used only for organophosphate poisoning. Oximes are effective only in organophosphate poisoning. They cannot reactivate the enzyme inhibited by carbamates. They are only for organophosphate poisoning. And the third important point you need to remember is the difference between PAM and DAM. And again you can remember PAM start with P. P means peripheral. So prelide oxime cannot cross the blood-brain barrier. It acts only in periphery. whereas DAM act at both the places, in the brain as well as outside the brain.
Now we will see how the enzymes work. This is acetylcholine esterase enzyme. It has two sites. One is called asteretic site and second is called anionic site. Asteretic and anionic site. Normally, acetylcholine binds to which site? If you remember chemistry, acetyl means ester. So acetylcholine is an ester. So it will bind to asteretic site. So normally, acetylcholine bind to asteretic site and it is broken. Okay? And the reaction is so fast that we will assume that this site is almost never occupied. So what happens is basically acetylcholine comes, binds, breaks. So it breaks so quickly that this site we can assume is almost always unoccupied. Okay? Now when the organophosphate poisoning occur, instead of this acetylcholine, organophosphate binds here. Acetylcholine की जगह पे organophosphate binds here. Now when organophosphate is bound, now acetylcholine do not get the place to bind. And when acetylcholine cannot bind, it cannot be broken. So the enzyme is inhibited. Acetylcholine esterase is inhibited. And organophosphate binding with the asteretic site is quite strong. So that means it will not automatically remove. So that's why it is irreversible inhibitor. Now what happens? We give oximes. Oximes bind to the unoccupied sites. That means anionic site. So oximes bind to anionic site. And after binding to anionic site, they will form a bond with the organophosphate. They bind to anionic site and form a bond with the organophosphate. And the bond between organophosphate and oxime is very, very strong. It is much more stronger than the bond between the organophosphate and asteretic site. So basically what happens when oximes bind, they will form a bond with the organophosphate and remove the organophosphate from the asteretic site. So asteretic site become free. So again acetylcholine comes, bind to asteretic site and can be broken. So oximes act as acetylcholine esterase reactivators. So the enzyme which has been inhibited permanently, it will become active again. Okay. Now the question is why oximes do not work in carbamate poisoning. So what happens in carbamate poisoning is carbamates are bigger molecules. They not only occupied anionic site but also asteretic site. So carbamates, they bind to both these sites, anionic as well as asteretic site. Now acetylcholine cannot bind, it cannot be broken, so enzyme is inhibited. But now even oximes cannot bind. So when the oximes are not able to bind, so they will not be able to reverse the carbamate poisoning. Okay? So oximes are effective only for organophosphate poisoning. Clear?
So now we'll start the parasympatholytic drugs. These are the drugs which stop the activity of parasympathetic system, and we will discuss these according to the organs on which they are working. Starting with stomach.
In the stomach, we have M1 receptors. Remember, पहले खाओ पियो फिर दिल लगाओ बाकी काम बाद में. In the stomach, M1 receptors are present. They lead to secretion of acid. But you need to understand a little detail here. If we see, this is the parietal cell of the stomach. Parietal cell contain a pump known as proton pump. So which secrete the acid in the stomach. Hydrogen potassium pump or proton pump. This is responsible for secretion of acid. But important to remember, parietal cells do not contain M1 receptors. Parietal cells contain M3 receptors only. So when we stimulate the M3 receptors, they will secrete acid. But what is the catch is, the neuron which is secreting acetylcholine very close to parietal cell, it contain the M1 receptors. So M1 receptors are present on gastric ganglia. So gastric ganglia will secrete the acetylcholine very close to the parietal cell. So this acetylcholine stimulate the M3 receptors and that will stimulate the proton pump. So now we can decrease acid by blocking the M1 receptors. If we block M1, acetylcholine will not come near the parietal cell. It will not stimulate M3, so acid will not be secreted. So these drugs which block M1 receptors are pyranzepine and talanzepine. Pyranzepine and talanzepine, they are selective M1 blockers. So where we can use them? Yes, they decrease the acid. And which disease occur due to more acid? Peptic ulcer. So these drugs can be used for peptic ulcer. But question is, can we use atropine for peptic ulcer? There are two questions. First question, can be used, and second question, will be used. Yes, the answer to both is no. Atropine we will not use. This is obvious because atropine not only block M1 but also block M2 and M3. So that will cause lot of side effects. But atropine is rather avoided in peptic ulcer, or we can say it is contraindicated in peptic ulcer. What is the reason? The reason is atropine will not only block M1 but it also block M3 receptors. And M3 receptors are not only present in parietal cell but they are also present on the smooth muscle of the stomach. So what happens when we give atropine? By blocking the M1 receptors, the gastric ganglia, it will decrease the acetylcholine release near the parietal cell. So that means it will decrease the acid secretion which we want. But it also block M3 receptor in the smooth muscle. So that means it will decrease gastric emptying. Gastric motility is decreased, peristalsis is decreased. So what happens after giving atropine is, although it has reduced the acid secretion in the stomach, but the acid which is already present, that cannot go down. So when the acid is not able to go down, that means the acid will keep on touching the ulcer and it will not allow the ulcer to heal. So that's why it is harmful in peptic ulcer. So any drug which decreases the gastric motility should not be used in peptic ulcer. So atropine is not used in peptic ulcer. Okay, pyranzepine and talanzepine can be used. They are selective M1 blocker, but atropine is not used. Clear? So these are effect of anticholinergic drugs on stomach. Then moving to effect on heart. Heart contains which receptor? Yes, M2 receptors. Remember we discussed पहले खाओ पियो फिर दिल लगाओ बाकी काम बाद में. So M2 is present in heart. So what happens when we stimulate M2 receptors? Yes, it will depress the heart. And what happens when we block M2? It will stimulate the heart. So M2 blockers, they can produce increase in heart rate, increase in conduction. So we can utilize them in which conditions? Yes, when they are low. So we can use M2 blockers in treatment of bradycardia and for treatment of AV block. And the drug of choice for both of these conditions is atropine. Atropine is a drug of choice for bradycardia and it is also drug of choice for AV block. Now, if we go into little bit detail, muscarinic receptors are also present presynaptically. They can act as a brake. M1 or M2 muscarinic receptors are present presynaptically. So when we give atropine, first of all, it blocks the presynaptic receptors. So when presynaptic receptors are blocked, that means brakes fail. And when the brakes fail, more acetylcholine is released. And when more acetylcholine is released, it will cause bradycardia. So atropine do not cause tachycardia right from the beginning. So when we give atropine, initially bradycardia occurs. Why bradycardia occurs? Because atropine block the presynaptic receptors. So brakes fail, more acetylcholine is released, and when more acetylcholine comes, it will decrease heart rate. But after some time, it block the postsynaptic M2 receptors. That means M2 receptor present on the heart. When M2 are blocked on the heart, then acetylcholine cannot produce the effect. So that will increase the heart rate. So atropine initially decrease the heart rate by presynaptic M2 blockade, and later on increase the heart rate by acting on the postsynaptic receptors. So atropine initially cause bradycardia, but later on cause tachycardia. Okay. Then third effect we can discuss is on bronchus. Bronchus contain which receptors? Yes, M3 receptors. And we know M3 cause bronchoconstriction. If we block M3, there will be bronchodilation. And bronchodilation will be useful in which condition? Yes, asthma. So we can use the M3 blockers in treatment of bronchial asthma as well as COPD. Asthma and COPD, we can use M3 blockers. And the drugs used for this purpose are ipratropium and tiotropium. The basic difference between the two drugs is ipratropium is fast acting, whereas tiotropium is long acting. So ipratropium is mainly used for acute attacks, whereas tiotropium is used for maintenance. Another important thing to remember, ipratropium is non-selective. It can block all muscarinic receptors M1, M2 as well as M3 receptors. But because it is given by inhalational route, so predominant action is on M3 receptors, but it can block M2 receptors also, which can lead to tachycardia. Remember, M2 blockade can lead to tachycardia. On the other hand, tiotropium do not block M2. It is selective for M1 and M3. So tiotropium has negligible risk of causing tachycardia. Okay? And from the name you can remember these drugs contain atropine in the name. Ipratropium. Atropium means atropine. Atropine like drugs, muscarinic blockers. Now important question, can we use atropine in treatment of asthma? Atropine will also cause bronchodilation, but we do not prefer atropine because of two main reasons. One, atropine is not available by inhalational route. It is need to be given by oral route or intravenous route, not available by inhalational route. In asthma patient, we will prefer inhalational drugs. Second important difference is, apart from causing bronchodilation, atropine can also decrease mucociliary clearance. So we do not want to interfere with that activity. So atropine is not preferred in asthma or COPD. Clear? Then moving to effect on urinary bladder. Again, the receptor is M3. M3, when we stimulate M3, what will happen? The bladder will contract. If we block M3 by giving anticholinergic drugs, the bladder will relax. So when the bladder is not able to contract, what will happen? Urine cannot be passed. So M3 blockers, they can cause urinary retention as a side effect. Urinary retention is the side effect of M3 blockers. Clear? Now, if a person is already having urinary retention, we will not like to further aggravate this. So M3 blockers are contraindicated or avoided in which patients? Which already have urinary retention, which patient? Yes, BHP. So M3 blockers, anticholinergic drugs, they are avoided in a patient with benign hyperplasia of prostate because already urinary retention is present. Now third important thing is, M3 blockers, they relax the bladder. So in which condition you will want to relax the bladder? Yes, it is overactive bladder. If the bladder is contracting without any purpose, we will want to relax it. So M3 blockers, they are used for treatment of overactive bladder. Indication is the overactive bladder, and overactive bladder mainly means its muscle is working more than required. And what is the muscle of bladder? Yes, detrusor. The other name of overactive bladder is called as detrusor instability. Detrusor instability. Detrusor is not stable. And when the detrusor is not stable, it is contracting without purpose. What will be the clinical feature? Yes, urine will be passed without our control. So that is called urinary incontinence. So anticholinergic drugs, they are used for overactive bladder or detrusor instability or urinary incontinence. But they can cause urinary retention in a normal person, and they should be avoided in a patient with BHP. Clear? Now coming to drugs. And the drugs you can remember as soft bladder. Soft bladder. So as the name tells, it will make the bladder soft, means it will not be able to contract. So when the bladder is not contracting, means we can treat overactive bladder. But these drugs can cause urinary retention in a normal person, and they are contraindicated in patient with BHP. The drugs are S for solifenacin, O for oxybutynate, F for flavoxate, T for tolterodine. Another drug is trospium, and DAR for darifenacin. Solifenacin, oxybutynate, flavoxate, tolterodine, trospium, and darifenacin. Now, important points to remember about these drugs. Because they are anticholinergic drugs, so all of them can cause a dry mouth as a side effect. So dry mouth or xerostomia is the adverse effect of all of them. Solifenacin and darifenacin, they are maximum vesicoselective. That means although they block the M3 receptor, but they have maximum effect to block M3 in the urinary bladder. So most vesicoselective are solifenacin and darifenacin. Then trospium is a drug which do not cross the blood-brain barrier. Do not cross the blood-brain barrier. So it has very less CNS side effects, particularly CNS side effects like delirium. They are absent in trospium because it is a quaternary amine, not able to cross the blood-brain barrier. Second thing, trospium, it is primarily excreted by kidney. So it is contraindicated in renal failure. It is primarily excreted by kidney. Clear?
Next is effect of these drugs on glands. Again, the receptor in the glands is M3. When we stimulate M3, there will be increase in secretions. So if a drug is M3 blockers, it will decrease secretions. So when the secretions decrease, the obvious side effect will be dryness. So dry eyes, dry mouth and dry skin are the adverse effect of M3 blockers. Now, due to decrease in secretions, they are contraindicated in children. Particularly atropine-like drugs, strong anticholinergic drugs are contraindicated in children. The reason is they decrease all the secretions including sweating. And we know sweating occurs to decrease the body temperature. So if we give anticholinergic drugs to a child, sweating cannot occur. So body temperature cannot be reduced. Plus the child, due to physical activity, body temperature keep on increasing. And if we have given anticholinergic drug, temperature will not decrease. So initially this will result in fever, which is also called atropine fever. And if we do not stop, it can result in hyperthermia, which can even lead to death of the child. So due to risk of hyperthermia, atropine is contraindicated in children. Now use. Anticholinergic drugs are used for pre-anesthetic medication. Pre-anesthetic medication. So first of all, pre-anesthetic. Whenever we want to give anesthesia, now this is the respiratory pathway. When we want to give anesthesia, normally we induce the anesthesia by giving intravenous anesthetic agent. So person become unconscious. Then we want to maintain the person unconscious, and that we do by giving inhalational route. So when we give any inhalational anesthetic agent, it will cause anesthesia to the person. Apart from that, all the inhalational anesthetic agent, they inhibit the ciliary function. Cilia is present in the respiratory pathway. All inhalational anesthetic agent, they inhibit the function of cilia. And what is the function of cilia? Cilia are used to remove these secretions. So if any secretion is produced here, it will be removed by cilia. So when we give anesthesia, cilia are not working, so secretions cannot be removed. So when secretions are not removed, there is chance that they will accumulate and that will lead to obstruction. And we do not want this problem. So the solution to this is Before the anesthesia, we give anticholinergic drug. So when we give anticholinergic drugs, now there are no secretion in the respiratory path. And when there are no secretions, even if cilia do not work, we do not worry. So before giving anesthesia, we are giving anticholinergic drugs. So before giving anesthesia, we give anticholinergic drugs as pre-anesthetic medication to decrease the secretion during the anesthesia. So anticholinergic drugs in the glands, their adverse effect is dryness. So they are contraindicated in children due to risk of hyperthermia, and they are used as pre-anesthetic medication to reduce the secretions. Next is effect of anticholinergic drugs on eye. Again, the receptor in the eye is M3. When we stimulate M3, it causes meiosis. So if we block M3, the drug will result in mydriasis. So anticholinergic drugs will cause mydriasis. So we discussed that for treatment of angle closure glaucoma, meiosis is required. So if a drug causes mydriasis, it is opposite to that. So that means they will precipitate glaucoma. So anticholinergic drugs are contraindicated in angle closure glaucoma because they may precipitate the acute attack. Now, is there any advantage of causing mydriasis? Mydriasis, it is required for fundoscopy. Mydriasis is required for fundoscopy. Fundoscopy means examination of retina. If we see, this is the lens. This is suspensory ligament. This is iris. The space between two iris is pupil. This is retina. And this is cornea conjunctiva. So when we want to examine the retina, we want to do fundoscopy. So we will keep the ophthalmoscope near the eye. But the light will pass only through pupil. So if we keep the ophthalmoscope without dilating the pupil, we can see this much of retina. That means we are visualizing only the central portion of retina. The peripheral portions are not visible at all. So that means we are giving incomplete report by only seeing the central retina. So if we want to examine whole of retina, then we need to dilate the pupil. So if we dilate the pupil, how the pupil become this much in size? When the pupil is this much in size, now we can examine whole of the retina. So mydriasis is required for fundoscopy because we want to see whole of the retina, not only the central portion of retina. So anticholinergic drugs in the eye, they are contraindicated in angle closure glaucoma, but they are useful in fundoscopy. In the fundoscopy, they are useful. Now there is another important thing. Again, this is lens, suspensory ligament, iris, space between the iris is pupil, this is cornea conjunctiva, this is retina. Now suppose we want to see an object which is near the retina. Suppose object is at this place. So normally the image forms on retina. Now if we see an object which is at greater distance or even more distance, now where the image will form? Image still forms on retina. But problem is, in earlier classes, we discussed that the distance of the image depends upon the distance of the object. But now we are saying whatever may be the distance of the object, the image will form at one point only. So how it is possible? Now this is possible because according to distance, the diameter of lens changes. Remember, lens is, this is the ciliary muscle. So the ciliary muscle contract and the diameter of lens changes. That will change the refraction and it will change only that much so that image forms on retina. Remember, only those objects are seen clearly whose image forms on retina. If the image forms here or here, it will lead to blurring of vision. The object will not be seen clearly. So ciliary muscle contract and image forms on retina, and this process is called accommodation. Accommodation. Now ciliary muscle is supplied by oculomotor nerve or third cranial nerve, and if you remember, 3, 7, 9 and 10 nerves, they are parasympathetic nerves. So third cranial nerve is the parasympathetic nerve. So when parasympathetic nerve is present, obviously the receptor here will be M3. That means M3 receptor stimulation lead to accommodation. So if we give M3 blocker, it will lead to loss of accommodation. And what will be the obvious disadvantage of loss of accommodation? The image will form here or here, and that lead to blurring of vision. So anticholinergic drugs, important side effect is blurred vision because of loss of accommodation. Now this ciliary muscle, the term used for ciliary muscle is cyclo. Like we use cardiac for heart, hepatic for liver, renal for kidney. Similarly, for ciliary muscle, we use the term cyclo. Now, because ciliary muscle is paralyzed, the condition is called cycloplegia. So, anticholinergic drugs cause cycloplegia that lead to blurred vision. So, anticholinergic drugs can cause blurring of vision. But this cycloplegia is very important. It is required for refraction testing. Refraction testing means to give the number of the specks. So anticholinergic drugs, they are used to give the number of the specks because they will cause loss of accommodation. And when loss of accommodation is not there, that means lens diameter do not change, then we can easily know the error in this pathway. That means refraction testing. Now revising the action of anticholinergic drugs in the eye. In the eye, they cause two actions. One is mydriasis, second is cycloplegia. The advantage of mydriasis is we can do fundoscopy. But the disadvantage is it make them contraindicated in angle closure glaucoma. Similarly, advantage of cycloplegia is we can do refraction testing, but it lead to a side effect of blurred vision. This is all we need to know in the eye. Now, one more thing to remember, the tone of ciliary muscle, this is age dependent. Now, if we want to do refraction testing in children or in adults, the choice of drug differs because it will depend upon whether a drug can cause cycloplegia in that age group or not. Now, tone of ciliary muscle is very high in children. As the age increases, the tone keep on decreasing. So, a child require very strong cycloplegic drug. Adult, weak cycloplegics can also work. Now, coming to drugs. Anticholinergic drugs which are used in eye are atropine, hometropine, cyclopentolate, and tropicamide. Now, out of these, atropine is the strongest cycloplegic drug. It causes maximum cycloplegia. So due to this reason, it is a drug of choice for refraction testing in children because they have very strong ciliary muscle tone. But problem with atropine is it is very long acting. Sometimes the action remain for more than 7 days. So if we use atropine in adults, it will cause blurring of vision for more than 7 days. We do not prefer atropine in adults because all other drugs are also effective. Whereas in children, only drug effective is atropine, so we have to use. So atropine is preferred in children because of strong cycloplegia, but it is not preferred in adults because of long action. So in adult, we will prefer the shortest acting drug, which is tropicamide. So tropicamide is preferred in adults because it is shortest acting drug. So this is effect of anticholinergic drugs in eye. Then effect of anticholinergic drugs on CNS. One particular drug called hyoscine. The other name of this drug is scopolamine. It is a CNS depressant. Hyoscine is a CNS depressant. And this CNS depressant action of hyoscine we are utilizing in motion sickness. Motion sickness. First of all, what is motion sickness? As the name tells, the person is sick when the person is in motion. Means when the person goes at high altitude in mountains and the person is traveling by a bus or a car or any vehicle, so the vestibular system of the person is stimulated. Due to motion, we know vestibular system is stimulated. Vestibular system is stimulated. And when vestibular system is stimulated, it lead to stimulation of passing the information to CTZ. And when CTZ is stimulated, it will lead to vomiting. So motion is controlled by vestibular system. When vestibular system is stimulated, it passes the information to the vomiting center, which will lead to vomiting. Now, when we give hyoscine, it depresses the brain, and that will lead to depression of this vestibular system of the brain. When vestibular system is depressed, information do not go to vomiting center, so vomiting does not occur. So we can give hyoscine for the prophylaxis of motion sickness, prevention of motion sickness. It prevents the motion sickness because the information do not go to vomiting center in the brain. One other important thing to remember, there is a similar term called as mountain sickness. Remember, motion sickness and mountain sickness are totally different diseases. Although motion sickness also occur in mountains, but mountain sickness is totally different disease. Mountain sickness never occur at small altitudes like Shimla or Manali. It is mainly seen at very high altitudes like Leh Ladakh. Mountain sickness seen at very high altitudes. At such high altitudes, there is decrease in partial pressure of oxygen. So person develops symptom due to hypoxia. There is respiratory problem in mountain sickness, whereas vomiting is the main symptom in motion sickness. And the drug of choice for mountain sickness is acetazolamide. Acetazolamide is drug of choice for mountain sickness. Remember, in motion sickness we are using hyoscine, but in mountain sickness we are using acetazolamide. Now one more action in the CNS. Anticholinergic drugs are used for Parkinsonism. Parkinsonism. Now, Parkinsonism, we all know, it is due to deficiency of dopamine in the brain. But problem is not that simple. What happens in the brain is there is balanced activity of dopaminergic and cholinergic system. In basal ganglia of brain, dopaminergic and cholinergic system have balanced activity. Suppose we have 100 dopamine, so we have 100 acetylcholine activity also. This is balanced. In Parkinsonism, there is degeneration of dopaminergic neurons in basal ganglia. So from 100 they remain 50. This lead to imbalance, and this imbalance is responsible for symptoms of Parkinsonism. So for treatment of Parkinsonism, we have to restore the balance, which we can do by increasing dopamine. So we discussed earlier, we can give levodopa, it will form dopamine, so balance will be restored. But if this system does not work, then second thing we can do is we can decrease acetylcholine. So if we decrease acetylcholine, balance will be again there. So this is the action of anticholinergic drugs. They can decrease acetylcholine and restore the balance. So it can be used in Parkinsonism. And this type is drug. Anticholinergic drugs are drug of choice for drug-induced Parkinson. Drug-induced Parkinsonism. Anticholinergic drugs are drug of choice, and the drugs which are used for this purpose, the main drug we use is benhexol. The other name of this drug is trihexyphenidyl. Benhexol. Apart from benhexol, other similar drugs include benchtropine and bipyridine. So these are the CNS actions of anticholinergic drugs.
Lastly, anticholinergic drugs can be used for treatment of some poisonings. So we already discussed atropine is a drug of choice for which poisoning? Yes, it is drug of choice for organophosphate and carbamate poisonings. Atropine is a drug of choice for organophosphate and carbamate poisoning. We already discussed. Now, important thing, what is drug of choice for belladonna poisoning? Read carefully. Before answering this question, look at the full name of belladonna. Belladonna is a plant. The full name is Atropa belladonna. So belladonna is a plant from which we obtain atropine. So do not say atropine is drug of choice. Belladonna poisoning means atropine poisoning because it is a source of atropine. Another plant from which we obtain atropine is Dhatura stramomyi. So belladonna poisoning or Dhatura poisoning or atropine poisoning are same thing. The drug of choice for these is physostigmine. So read carefully. They commonly try to confuse you in the MCQs. They write drug of choice for belladonna poisoning is, and the first option they write is atropine. Do not mark that. Belladonna poisoning is atropine poisoning. The drug of choice is physostigmine. Clear? Now another poisoning for which we can use atropine like drug is mushroom poisoning. Particularly early mushroom poisoning, atropine is a drug of choice. Early mushroom poisoning, atropine is drug of choice. So there are two type of mushrooms. We'll discuss the mushroom poisoning here. So two type of poisoning can be seen with mushroom. One is known as early mushroom poisoning and second is called as delayed mushroom poisoning. Now important to remember, these are not the same disease if it present early or present late. These are two different mushroom species causing these symptoms. Early mushroom poisoning, it is caused by a species known as inocybe or clitocybe species of mushroom. They cause early mushroom poisoning. Whereas delayed mushroom poisoning is caused by Amanita group of mushrooms. Amanita, one of them is Amanita muscaria. They cause delayed mushroom poisoning. Now these are totally different diseases. Early mushroom poisoning, it presents as symptoms similar to cholinergic excess. That means similar to organophosphate poisoning. So same symptoms, like there will be increase in secretion, there will be contraction of pupil, there will be bronchoconstriction, everything same like organophosphate poisoning is there. So because the symptoms are same, the treatment is also same. The drug of choice for early mushroom poisoning is atropine. Atropine is a drug of choice. But on the other hand, delayed mushroom poisoning, although the name is confusing, it is caused by Amanita muscaria. So it look like it must be containing muscarine. So it will produce stimulation of muscarinic receptors. No, the amount of muscarine which is present in Amanita muscaria is very, very small. But it contains different substances which have plenty of anticholinergic effects. So delayed mushroom poisoning is also known as hallucinogenic mushroom poisoning. So here mostly the anticholinergic substances, they are causing these symptoms. So symptoms are similar to atropine poisoning. So very important thing to remember, for delayed mushroom poisoning, atropine is contraindicated because it is a type of mushroom poisoning. This is very important to remember. The management is purely symptomatic. Atropine is contraindicated. So early mushroom poisoning, atropine is a drug of choice. Delayed mushroom poisoning, atropine is contraindicated. Clear?